I welcome all the guest faculties, the chairpersons, our office bearers and participants in this web conference of 18th annual meeting of Jharkhand Ophthalmological Society. Now, I invite our president, Dr. Halimuddin sir, for his presidential address.
I, Dr. Halimuddin, as a president of JHOS, welcome you all, especially our guest faculty, Dr. Partha and Das. We are holding the annual web conference of JHOSCON 18 since we have established our own state conferences, which was started in the year of 2002 after separation from BOS, Bihar Ophthalmological Society. And we are continuing since then, and we are trying to take it on its heights in the near future, and especially our members, secretary, scientific committee chairman, and our past presidents and all have took pain and labored hard to bring this society up in the national as well as state level and international level. I welcome you all in this webinar, and I ask my secretary to start the webinar. Thank you.
Our Chairman Scientific Committee, Dr. Bharti Kashyap, will take over from here. Dr. Bharti, you unmute yourself, please.
Okay. So today we are holding, as I said, the web conference of 18th annual meeting of the Jharkhand Ophthalmological Society. And this annual web conference is divided into 4 parts. Today we are conducting the first part. So today's webinar is divided into 2 sessions. First session is Dr. P Kashyap extramural oration, which will be given by Dr. Partha Biswas, and guest lectures by Dr. Chandrima Paul and Dr. Rupak Kanti Biswas. It will be followed by a small virtual award ceremony. Session 2 is Dr. V.S. Gupta Gold Medal Competitive Free Paper Session, and that would be conducted by our secretary, Dr. Bibhuti Bhushan. So, before I invite Dr. Partha Biswas for his oration, I would like to introduce our legendary recipient of this oration, Dr. Partha Biswas, Chairman Scientific Committee, AIOS. No. Dr. Partha Biswas is Director of BBI Foundation, Kolkata. He is Chairman Scientific Committee of AIOS. He has innumerable national and international awards, presentations, and publications to his credit. He is the past Chairman, Academic Research Committee of AIOS, and presently he occupies the hot and most coveted seat of Chairman Scientific Committee, AIOS. So welcome, Dr. Partha Biswas. And over to Dr. Partha Biswas for his oration.
Thank you very much, Dr. Bharti. May I share the screen now?
Yes.
Is the screen audible and visible? And am I audible? Thank you very much. It's a matter of great pride, and I'm absolutely humbled by this prestigious oration that I'm supposed to deliver. A man of such great stature as Dr. Bharti Kashyap someone who was legendary, who was a teacher of teachers in Jharkhand and beyond, has committed a very prestigious seat in the memories of every one of us, known nationally and internationally. If I might say a few words about Dr. Bharti Kashyap, it's very small, simple, but as well as extremely deep. The foundation of the hospital that Dr. Bharati Kashyap has laid is not only a hospital by its repute, by its tradition, but it is a hospital with a hospitality to one and all patients of the region of the eastern India, not only of Jharkhand itself. The hospital was a dream of late Dr. Kashyap, and with the hospital came the flood of patients, the flood of memories, cherished memories that anyone entering the hospital would remember the founder as an luminary in the state of Jharkhand. Dr. Kashyap completed his MBBS from Darbhanga Medical College and Hospital in 1955. He did his Master of Surgery in Eye from DMCH, Bihar in 1958 and DLO in 1962 from PMCH, Patna. He was appointed as Civil Assistant Surgeon in 1956. He was State Officer Trachoma Control Pilot Project in Bihar and Aligarh in 1960. Assistant Professor in RMCH from 1962 to 1965 and Associated Professor from 1965 to 1975. He became Professor and Head of Department from 1975 onwards. He had a wide vision and conducted blindness relief camps wherever he was posted. He happened to be in the top slot for many new procedures that were adopted by the ophthalmologists of India. Among the first few to start 10-0 nylon stitches and intraocular lens implantation during cataract surgery. He was the first to start keratoplasty in this region in 1979 and amongst the pioneers for combined cataract and glaucoma surgery. He began operating through the microscope from 1979. He was an excellent teacher, an exemplary father, and a husband. If you see very brief biodata, it shows the revolution which Dr. Kashyap actually had brought about in the medical field, in the ophthalmological field, in his career, and every bit he transmitted to his teacher, to his patients, and to his students. Thereby, to his students, he lit a candle, and that candle that he lit for them has enlightened many, many, many other candles that have been transmitted from the past to the present and will be transmitted to the future. So this was Dr. B. Kashyap, a luminary in the field of ophthalmology, a person who is revered by everyone who has come in touch with him. I thank Jharkhand Ophthalmological Society for having an position in his name. I am extremely humbled to give this oration today. It is the light to candle and for these tender eyes. Tender eyes need the most tender touch. And it is remarkable to understand that there are 1.4 million eyes of a child that is blind today. And in this blindness, these children are going to grow up and think of the years and years of blindness that they are going to suffer from. These tender eyes need special attention, need special thought. And it is the prerogative of every anterior segment surgeon to do something for these tender eyes. Learning to do a pediatric cataract is not so difficult, but it requires patience, it requires learning, because the first step of anterior capsulotomy is quite different because of the elasticity of the anterior capsule. And this is the first step towards the success of a pediatric cataract. The next part is the simplest, is the easiest. Removal of the cortical matter and the lens matter, which is very, very soft, is nothing of a challenge. But the next part, carving the posterior capsule rhexis, is again a tough part and has to be learned with meticulous detail. Grasping that edge that you have created with a puncture of the posterior capsule, re-grasping it from the other side, and then carving out a neat posterior capsule rhexis that should be approximately 3.5 to 4 millimeters, requires practice, requires diligence, requires teaching. The intraocular lens has to go in the bag between the anterior capsule and the posterior capsule rhexis. And the leading haptic must go straight into this area. And this area must be carved out so well that it can lodge the single piece intraocular lens. This is another case of a child in which the mother had suffered rubella infection. And you can see that it is an opacified cortical matter and nucleus matter. We do not know exactly what is in store for us, but after doing the capsular rhexis, it looks that the full posterior capsule is totally scarred and totally fibrosed. So we place our intraocular lens in the bag, a multi-piece intraocular lens, and then puncture that area with the MVR blade and carve out a posterior capsular rhexis through the side port with the vitrector. So the vitrector is the tool to make a posterior capsular rhexis. Let's come to this patient with iris coloboma, with lens coloboma. So the lens coloboma has to be supported and the iris coloboma has to be supported with the high molecular weight viscoelastic. Staining the anterior capsule is the next step. And once the anterior capsule is stained, then the anterior capsule rhexis needs to be done. As you can see that the anterior capsule rhexis is going so far nearly the roots, but this is important, and the adequate size of the anterior capsule rhexis is a must. Then making posterior capsule rhexis, and the posterior capsule rhexis has to be carved out and made adequate. Then filling in the intraocular lens in the capsular bag, but then this is a decentered capsular bag with the intraocular lens. So in goes the CTR, and the CTR has to be such that it should be just adequate sized, and then the posterior and the anterior vitrectomy has to be done and removed. Now this is a patient in which there is liquefied cortex, and all that you have to do, remember that the anterior capsule is going to be as elastic, and this anterior capsule rhexis might give way. So removal of the liquefied matter, cortical matter, is mandatory. Taking off the anterior capsule and removing the amount of cortical matter, and the rest of the things look to be quite easy. So doing the posterior capsulorhexis again centrally and getting it out, and then placing the intraocular lens within the capsular bag. But look at that. So the anterior capsulorhexis was not too well made. That needs to be repaired, because remember the fact that this anterior capsule is going to ossify and is going to stretch out unidirectionally and create a problem. The anterior vitrectomy is a must from the posterior capsulorhexis of every patient. This case has a posterior lenticonus, and with all posterior lenticonus eyes, we know that there is dehiscence of the posterior capsule and is susceptible to a rupture. So no hydrodissection in this case, and removal of the anterior cortex and the liquefied nucleus matter needs to be taken place. The removal of the cortex displays that there is an opacification of the posterior lenticonus. So we have with us a little bit of a problem. So this opacified area has to be neatly carved out, and the posterior capsulorhexis has to be made. So the stretched and not stretched part of the capsule have to be negotiated. And then with the vitrector, the anterior vitrectomy needs to be done. Placing in intraocular lenses inside the capsular bag is the most important pertinent matters. So a few pearls for the pediatric cataract management by our comprehensive ophthalmologists. A detailed preoperative examination is mandatory. An accurate biometry on the table is what is required. An adequate rhexis. The posterior capsulorhexis has to be done well. Intraocular lens in the bag and anterior vitrectomy. Post-operative infection control and a post-operative abnormal management and a lifelong follow-up is what is required for all these tender eyes. And if done well, these eyes will enjoy the light of the world. And it is the prerogative of all of us anterior cataract surgeons to take up the call and to do our share of posterior of the pediatric cataract for these patients and help alleviate the pediatric blindness in our country. Thank you very much for your patient hearing.
Thank you, Dr. Partha, for the excellent oration. So now I invite Dr. Chandrima Paul, and before I invite her, I would like to introduce her. She's our honored guest speaker, Dr. Chandrima Paul. Guest speaker.
Should I share my screen, or are you going to share your screen first?
First, I have to introduce you.
Okay.
Our honored speaker. So,
Please unmute Dr. Bharti. Please unmute.
Dr. Bharti, you are muted. Please unmute yourself.
yes. We welcome Dr. Chandrima Paul, our guest speaker. She is Director of BI Foundation, Kolkata, and General Secretary of the Glaucoma Society of India. She is FRCS Glasgow and PhD Ophthalmology. She is trained at Glaucoma Service Moods Eye Hospital, UK. She is recipient of the Chandra Award AIOS 2006. She is the Chief Instructor she was chief instructor at World Glaucoma Congress 2013 and 15. She conducted the Hooghly River Glaucoma study, which was the largest study, and she was the principal investigator. So with this, I welcome Dr. Chandrima Paul for her guest lecture.
Thank you very much, Dr. Bharti. Okay, you have to stop. Thank you very much, Dr. Bharti and Dr. Kashyap and the Jharkhand Ophthalmological Society for having me here. It is indeed a pleasure for me to be here with you this evening. Can you see my screen?
Yes, yes, you are audible and visible.
Yes, yes.
Okay. So in the next few minutes, I'm going to take you through trabeculectomy complications, prevention, and management. So surgical therapy of glaucoma is usually resorted to in case of failure of medical management, and it was described in 1968 by Kahns. As you all know, to date, it is the gold standard for glaucoma surgery in trabeculectomy. Wound healing at conjunctival and episcleral plane, limiting factor for the success of trabeculectomy. Antifibrotics, 5-fluorouracil, less used nowadays, but mitomycin C has been widely used for wound modulation to improve the surgical success. Ologen is a new entrant, and introduction of the antifibrotic agents have actually improved the surgical success, but sometimes at the cost of post-operative complications. So trabeculectomy actually provides a non-physiologic route for aqueous outflow, and complications may occur despite the best of efforts. In all surgeries, we pray for the wound to heal. This is one surgery where we pray for the wound not to heal. So timely detection and management of these complications is vital for a good surgical outcome. And these complications can be divided into perioperative and post-operative complications. So that's actually the precarious balance where you stand when you're actually doing glaucoma surgery, trabeculectomy to start with. You have to maintain an absolute critical balance between the flow and the scarring to have your optimum results. So this is a small tip of perioperative application of mitomycin C. That is a conjunctival separator which I designed, and that helps in not touching the edges of the conjunctiva when you're applying mitomycin C. It's a complete, it's a simple instrument, and that helps you to actually apply your mitomycin C with the absolute no-touch technique around the edges of the conjunctiva. Next, we move on to Ologen, a small video to just show you. This is one of my older surgeries. I no longer do the triangular flap, but releasable suture is absolutely mandatory if you're using Ologen, because then only you get the benefit of Ologen, that you can tighten the IOP during the immediate post-operative period by releasing the suture. And that's the Ologen being placed is relatively simple. You just have to place it over your scleral flap and then pull the conjunctiva over it, and that's your Ologen. And now I'll show you a dreaded complication that might occur during trabeculectomy. This is, see what I do, a tear of the flap. So not to pant, not to get disturbed, but then carry on with your surgery and then place the flap as it was and suture the flap to the edges. So this you can actually do it with a cool mind and perseverance, and you actually can get absolutely the same results as you would get if your flap hadn't torn. So you just have to basically suture your flap over that and it's absolutely fine. So there you are. And next I'll show you one more complication which, this is the flap sutured well. And there's one more complication which is dreaded by all glaucoma surgeons, and this happened to me when I was doing a live surgery. So see what I do, and there you see there's a perforation. So that's it. So there again, don't lose your nerves. Close that incision site completely well and then go to a fresh site and then start all over again, and that should take care of your surgery. So I've closed that and I went to a fresh site and started again. So these are some of the dreaded complications which you can get if you're doing glaucoma surgery, however good a surgeon you might be. So consider topical or bulbar anesthesia, few surgical pearls per operative. Never use tooth forceps to handle the conjunctiva, because otherwise buttonholing of the conjunctiva can be one of the most common complications that you come through. Aim for watertight conjunctival closure. Lower high preoperative intraocular pressure. I always use mannitol, and never leave the operating room with an unclosed leak. Next, we move on to early postoperative complications. So that's a high intraocular pressure with a deep anterior chamber, usually because of tight closure of the wound. You need to do a gonioscopy to rule out the obstruction to flow to the sclerostomy site. And obstruction is rare and is usually due to fibrin blood, vitreous iris, or imperforate decimus membrane. But if the obstruction is with fibrin and blood, it is generally transient and clears up. But if the obstruction is with iris or vitreous, then maybe intervention is required. Management here would be to separate the edges of the scleral flap with digital pressure. We generally apply pressure over the sclera on that area with the Johnson's bud or something like that, and then we apply pressure at the lower lid to actually open it out. The IOP depth of the AC and the height of the bleb should be noted after the digital pressure. These measures may have to be repeated multiple times. If the IOP remains high, removal of the releasable suture or sutural lysis can be considered. Next, we move on to high intraocular pressure with a shallow anterior chamber. This generally happens in pupillary block, responds well to a laser or surgical iridectomy. Or there could be aqueous misdirection. That's initial management consists of aqueous suppressants and cycloprages. If that doesn't work, then we go for surgical treatment as required. Suprachoroidal hemorrhage, you need to do a USG here. USG demonstrates the blood there, and in the suprachoroidal space, a small hemorrhages can resolve. Here you need to do subsequent USGs actually to see the lysis of the blood, and a larger one actually might require draining. And low intraocular pressure with shallow flat anterior chamber and a flat bleb, as you see out there, generally due to conjunctival wound leaks. So hypotony without a visible bleb should alert the surgeon of the possibility of a conjunctival leak, and you have to do a Siedel's test, usually localizes the site of the leak. We generally do conservative management, which consists of bandage, contact lenses, collagen shields, etc. But if it does not help, then definitely you have to go for intervention. Serous choroidal detachments, precipitating factor is generally hypotony, conservative therapy that consists of frequent topical steroids and cycloplages with or without oral steroids generally helps. And rarely there can be an inadvertent cyclodialysis cleft. Low intraocular pressure with shallow flat anterior chamber and elevated blab, that is excessive filtration, overfiltration due to a loose scleral flap suture, usually resolves spontaneously. Treatment is recommended when the AC is very shallow or if hypotony is associated with large choroidal effusions. So early postoperative period pearls would be digital massage, helps in formation of the bleb. Laser suturolysis and releasable sutures are useful techniques. Tackle one suture at a time to avoid hypotony, especially in eyes that have received antimetabolites. Early recognition of signs of scarring and appropriate treatment improves the success rate of trabeculectomy. Always try conservative treatment with encapsulated blebs. Aqueous misdirection is a difficult complication to manage. The best approach is to prevent the initiating factor, that is sudden shallowing of the AC in high-risk cases. Common causes of serous choroidal detachment is the hypotonic eye. After trabeculectomy, it is more common in older patients, so choose your patients very carefully. One of the mechanisms suggested regarding choroidal detachment is that the dissociation of the ciliary body of the hypotonic eye allows the aqueous humor to flow into the suprachoroidal space. Another explanatory measure is that hypotony enhances the vascular permeability of the choriocapillaries, and in older individuals it might contain relatively fragile connective tissue which could enhance the fluid movement through the uveal tissue and the vascular wall. So choose your patients for trabeculectomy carefully, especially when you're operating on older patients. Late postoperative complications, chronic hypotony, like you see there, disc edema with macular folds, but generally the IOP has to be really low, 5 millimeters or so for almost 3 months or so, then only you can actually have visual disturbances. Bleb leak is one of the commonest things that you see. There could be a buttonholing or there could be a bleb leak due to other reasons. So you need to do a Siedel's test, which would be positive. Generally, we manage it conservatively. If that doesn't help, then we use the cyanide glue or fibrin tissue glue. If that also doesn't help, we go for autologous blood injection. And remember, autologous blood injection has to be very fast. You actually draw the blood from the antecubital vein, and within seconds you've got to inject it into the bleb, because we are using anticoagulants there, and we inject about, say, 0.1 cc into the bleb. And bleb revision is the last, of course, where you need surgical intervention. So failing or failed blebs, late failure of blebs is mainly due to fibrosis at the conjunctival and episcleral interface with a patent sclerotomy, and rarely due to obstructive sclerotomy. Management depends upon the cause. External revision with needling using antimetabolites is common and a recommended procedure for bleb failure due to scarring. Internal revision with laser can be tried for sclerostomy obstruction. And when these measures fail, a repeat glaucoma surgery has to be done. So symptomatic blebs, as you all know, patients come back with blebitis and with endophthalmitis. I won't go into the details of this in the interest of time. All of us know how to manage these. Late postoperative complications, a few pearls here. That is, early postoperative hypotony leads to chronic hypotony. So avoid low IOP, especially in treated eyes with antimetabolites. Patient education is very, very important. Chair time here is very important to minimize the risk of bleb leak and infections related to it. Failure of the bleb can occur at any time following surgery. Post-surgery follow-up is a must for all patients. Tear film disturbances are common and can cause asymptomatic blebs, so we need to give artificial tears. And immediate and aggressive treatment of bleb infections can actually salvage the eye. And successful trabeculectomy is a stable surgical fistula. The one thing required to keep a fistula patent open is flow. The principal and most challenging complication is scarring, so prevention is always vastly preferable to cure. All of us who have been doing trabeculectomy for the past 30 years would have seen blebs which are overhanging. So I'll leave you with a video which I did a surgery on an overhanging bleb. It was referred to me from outside the state, and this is how it was managed. So that's the overhanging bleb that you see out there. Just look at it, it's almost approaching the pupillary area. And preoperatively, I planned the surgery that I would be excising the extra part of it, keeping the bleb intact, and then would be actually applying compression sutures to lift it up. So a very delicate dissection of the bleb, just to, delicately loosen it from over the cornea, so that its attachment to the cornea is removed. And once you've actually done that, this is actually the difficult part where you have to actually hold your patients and do it effectively. But once you've got the edges to turn, the lifting is not that easy, as you can see out here. Getting the edges to turn was a little bit of a delicate task, but once the edges turned, then I could actually move it over the conjunctiva across the limbus. And there again is a little bit of an addition which you've got to release again a little delicately so that you don't injure the bleb. And this requires a delicate dissection. And once you've done that, then you just excise that part off. Here you have to be very careful that you do not nick any part of the bleb that causes a buttonholing or a bleb leak. So that is what you've got to be very careful about. And this whole thing is excised. And once I have excised that, then my job is actually pretty simple. But these blebs have a tendency to again grow and come over the pupillary area if I leave it like this. So I would not leave it like this. I would actually go for compression sutures so that I make sure that this bleb, though it has a tendency to actually grow downwards, is actually limited by the sutures, and it actually remains in its place. So just compression sutures crisscross across the bleb. That is what I did basically. So just through that, and again you have to be careful here as well that you don't puncture the blood with the tip of your needle. But this has been actually practiced extensively to lift up blips and works very well. And this patient actually is doing very well now. And the blood is intact and no longer complaining of something coming down over the eye, and at the same time irritation and dryness of the eye. So that's it basically. And I just tighten it there so that it doesn't actually hang over again and go in its unnatural path. So there you are, and it's pretty firm out there. So once I've finished off with that, that's the exercise portion which I so post-operative, the patient is doing well, and that's day 7, and then 3 months post-operative also. The pressure is maintained and the patient is doing well. Thank you very much for your attention. I'll just stop sharing.
Thank you so much. You have really enriched everyone, because most of the people, doctors in this region, they do glaucoma and cataract both. So I hope that it has, most of us must have seen it and it is themselves. So a lot of doctors are practicing glaucoma here in this region. So thank you so much, Dr. Chandrima. And now I invite Dr. Kanti Biswas, and before that I would like to introduce him.
Madam, will you please allow us to congratulate her for becoming the General Secretary of GSI? Madam, congratulations.
Thank you very much. It's your support actually which made it.
We were all there to support you. Yes, ma'am. We are all there behind you, with you. And
Thank
please
you.
take care of us, yeah?
Thank you. I look forward to your participation in the GSI activities.
Definitely, madam. Yes.
So Dr. Rupak Kanti Biswas is Chairman, PG Education Committee, Ophthalmological Society of West Bengal. He is Executive Director and Senior VR Surgeon at Netralayam and BBI Foundation, Kolkata. He has developed VR units in 3 different rural eye hospitals. He is recipient of Ray Buckler Award from American Retina Society, U-Retina Award from European Retina Society, FIFA and International Hero Award from AIOS, and Best Innovation Award from IZOG. So I welcome you, Dr. Rupak Kanti Biswas, for your guest lecture of cataract surgery in presence of diabetic retinopathy. You are not audible. Please unmute yourself.
Am I audible now?
Yes.
Okay. Okay. So thank you, JHOSCON and Dr. Bharti for giving me this opportunity. I'm really honored to be here today. And after these 2 excellent video-based presentations, so this is actually not a video-based presentation, but I can tell you this is not our dry topic, but yes, this is going to be a something something which will be very, be as sweet as diabetes. Can you see my slides?
Not yet, Rupak.
Sir, please open the Zoom and share screen, sir.
This is, I've started sharing. Yeah, can you see it now?
Yes.
Yes.
Yes, yes.
Good. So this is again very close to all of us. This is cataract surgery along with diabetic retinopathy, how to go about it. Most important part of it is that these are the 2 comorbidities which run together. So this is the comorbidities which we cannot separate each of them. Cataract and retinopathy. In fact, actually 20% of the all cataract surgery is being done on diabetics. So you can understand that 20% of the cataract surgery we are doing, along with they have either some form of diabetic retinopathies. So this is a slide which I am showing you. This is again the treatment of diabetic macular edema per se can lead to the progression of the diabetes, which is, as we know, which is more common with the steroid injections, which goes up to 60% of the cases. What is aim of these surgery is to improve vision, is to improve few fundus view, and further treatment for the retinopathy, those who are having retinopathy. So when should we do what? These are two comorbidities together. I will just try to explain to you at what scenario, with clinical scenario, how to go about it. The special attention, as you all know, that they have the higher risk of complication. You can enlist the whole list of complication, of which we will mainly focus of diabetic macular edema and CME, and how the effect of macular edema on cataract and the cataract on macular edema. So the hurdles here is obviously, as you all know, there is a surgical meiosis can occur more likely. The anterocapsular contraction can be there. This is more fragile, leading to more increased chance of posterocapsular rupture. And cataract is more sticky, leathery, and we need to always try to put a larger diameter of IOL because in future for the panretinal photocoagulation if needed. Now let me share the guidelines how to go about it. So if we have a cataract with nil to moderate amount of the NPDR without any maculopathy, and the cataract surgery you are planning, so assess maculopathy, follow up, and then with a good systemic control. So now if you have a NPDR, non-proliferative diabetic retinopathy, and you have a maculopathy with good retinal view, the cataract is not that much, and you can still do the amount, you get a clear picture of OCT to document the amount of the macular edema. Go ahead for do the OCT, treat the macular edema first with anti-VEGF or laser, and then once the maculopathy is stabilized, and control the blood sugar level properly, and then go ahead for the cataract surgery. There is no hurry for the cataract surgery in presence of diabetic macular edema and when you have a good retinal view. Now, similar condition, when you have a poor retinal view, so if you still have non-proliferative diabetic retinopathy and along with maculopathy, and the retinal view is not very clear, but still you can do OCT. So you can treat the macular edema with anti-VEGF and laser if it is possible, again stabilize maculopathy, and then try to do cataract surgery. But once it is not possible to do OCT, then combine cataract surgery along with anti-VEGF and steroid. I will come across what we should use, whether anti-VEGF or steroid, which should be more important in these cases. And then once the cataract surgery is done, rather once the combined procedure is done, cataract surgery along with injection, intravitreal injection, then postoperatively assess maculopathy and again do OCT, and accordingly we need to treat the maculopathy part of it. Now, if you have a proliferative diabetic retinopathy along with maculopathy, and you have a significant amount of cataract, and you have tried OCT, you still not able to do it, so you have to do combined cataract surgery along with anti-VEGF. But before that, we need to rule out whether there is no tractional retinal detachment. So if you have a tractional retinal detachment along with significant cataract, I will come back later. So that situation, we will go for combined both retinal surgery and cataract surgery combined together. But if you don't have any tractional detachment, but you have a simple PDR, proliferative diabetic retinopathy along with maculopathy, then we will go ahead for combined cataract surgery with anti-VEGF and then treat them with PRP and macular laser photocoagulation if needed. So this PRP should be started within 2 weeks. This is, I'm talking about this, there may be a controversy because of this anti-VEGF, whether it is needed along with this, but if you have a maculopathy, this is always wise to use anti-VEGF treatment. Now, once you have done cataract surgery and whether you are, there is always a chance of near about 15 to 20% chance of progression of the diabetic macular edema. Like if you have a preoperatively, if you have a non-center involving macular edema, there is almost near about 15% chance that it can progress to central involving diabetic macular edema. So that's how we need to be very cautious about it. Post-operatively, after cataract surgery, follow them up very rigidly. Now, how do we differentiate it, whether it is a pseudophakic CME or it is a diabetic macular edema, or you can have both combined together. Now, at this point of time, I would like to make a comment that even the pseudophakic CME chance is much higher in an uncomplicated diabetic patient or uncomplicated cataract surgery in a diabetic patient. So, because of the leakiness of the blood vessels, even if the patient may not have the overt diabetic maculopathy or overt diabetic retinopathy, they can lead to, once the inflammation sets in, then they can lead to pseudophakic CME very easily. So how to differentiate it? If we do a fluorescein angiography, then there is what we call as a hot disc. You can have a disc staining along with these are the three pictures I am going to explain to you. The first picture, this is picture A, is showing a central macular pattern, macular edema pattern, where the Henle's layer having a consisting of the cysts and hard exudate and microfoci. So this is going to be a simple diabetic macular edema. Here you can see the hard exudates are there. Is a chronic diabetic macular edema is chronic. The B is a pseudophakic CME with a central pattern of SRF. You can see the typical petal-wide distribution of both the sides, and there is a little bit of SRF. This is a purely pseudophakic. But sometimes you can have both hard exudate, and there are some amount of the macular edema which is away from the fovea a little bit, and you have a subretinal fluid. This is a mixed variety. So once you have the both pseudophakic CME or diabetic macular edema, the diabetic macular edema should be treated along with pseudophakic CME. And diabetic macular edema treatment would be always like the following the protocol. So if you have a diabetic central involving diabetic macular edema, anti-VEGF injection is the first line of therapy, followed by laser photocoagulation if needed whenever you have a visible microaneurysm. Now, once we let us remove the DME part of it. If we have the DME has been excluded, but still you can have this kind of different situation. You can have a cataract with PDR, you can have cataract with vitreous hemorrhage, cataract with tractional detachment, you can have cataract with neovascular glaucoma, and you can have there is no visibility at all along with the cataract. So I will just go a quick through of this. This is a very well treated PDR. After doing uncomplicated cataract surgery, patient recovers 6/6/20/20 vision. So this is it is not that always that the patient will not gain the significant vision. That is not true. This is a situation when you have extrafoveal TRD. This is, you can see the fovea is spared, and here you have a TRD involving the fovea. You can see this TRD area is involving the fovea. So in both the cases, surgery is the only option. So if you have combined both significant cataract surgery, combine both cataract surgery and together. This is an example of a combined retinal detachment. When you have a tractional and rhegmatogenous retinal detachment, you can see the bullousness of the retinal detachment here. That shows clearly that it is a combined retinal detachment where cataract surgery and retinal surgery has been done completely, and retina is very well settled and leading to significant improvement of vision. So to take home is that you have a preoperative diabetic retinopathy. If you have the cataract surgery outcomes, these are the risk factors. Younger patient, female patient, those who have the very high preoperatively HbA1c level, higher fasting glucose sugar level, or acute normalization. That means if you control the blood sugar level very rapidly, and these are the situation where you have more chance of progression of the diabetic retinopathy. And once you have the capsular rupture, then the chance of progression of the proliferative diabetic retinopathy is also higher. So with this take-home message, thank you. I would like to re-emphasize the fact that whenever you have a combined of diabetic maculopathy or diabetic retinopathy along with cataract surgery, please focus on diabetic macular edema to be treated first, stabilize it, and then do the cataract surgery. There is no harm in stabilizing the diabetic macular edema and then do the cataract surgery. The outcome is always much, much better. But at the same time, you need to remember, even if you have controlled it, you have to have them a very close follow-up, because after cataract surgery, there is always chance of progression. And regarding the whether you want to use anti-VEGF or steroid is always a better option, because cataract surgery induces inflammation. It does not causes more amount of the anti-VEGF to get produced into the eye. So you need to control the inflammation in that area. So combining cataract surgery plus steroid is better option rather than combining anti-VEGF. But if you have a pre-existing macular edema along with proliferative changes, anti-VEGF is the better option. Thank you. Thank you so much. I'll stop sharing.
Thank you so much. Today I found that our guest speakers have really selected very nice topics. For tender eye, that the pediatric cataract, then trabeculectomy, then Dr. Rupak's talk on cataract surgery in diabetic retinopathy. All topics are really interesting topics, and I thank you again, all of you. And then I hand over to Dr. Bibhuti Bhushan, conducting the second session. Is Dr. V.S. Gupta Gold Medal, free paper competitive session. And all the students, all the presenters, they have already rehearsed everything. And so now over to Dr. Vibhuti Bhushan. Second.
Thank you, Dr. Bharti. Am I audible?
Yes.
Okay, so we are now into the second session of the conference. It's a very important session because all the young ophthalmologists, they are gearing up. They have geared up for this session. First, I would like to share the slides. Actually, this is done in the memory of Dr. V.S. Gupta, who was born on 15 January 1934. And he left for his heavenly abode at a very early age of 47, not just before reaching 48, in the year 1981 on 10th December. He was the professor in the Department of Ophthalmology of Darbhanga Medical College. He pioneered use of sutures and keratome with scissors in intraocular cataract extraction surgeries in Darbhanga Medical College and in eye camps organized in the remote places of Darbhanga. He started squint surgery and he started trabeculectomy also in the Department of Ophthalmology of Darbhanga Medical College. He is survived by his writer wife, Mrs. Kala Gupta, and two daughters, Aditi Kashyap, who is based in US and is a homemaker, and our chairman scientific committee, Dr. Bharti Kashyap, is a proud, we are proud to have her as a chairman scientific committee of JHOS, and who is also the director of Kashyap Memorial Hospital, Ranchi. With this, I would like to share a small video about this session.
Bibhuti,
Yeah.
we welcome Dr. Vidya sir. Dr. Vidya Bhushan Sinha has joined. He is the head of the Department of RIMS and the most favorite student of my late father, Dr. Professor V.S. Gupta. He is his student and most favorite student, Dr. Vidya Bhushan Sinha. Sir, we welcome you, sir. You have muted yourself. अच्छा कोई बात नहीं है. You start your introductory video. Just that.
I'll just start this video. Is it visible?
नहीं.
Okay.
तो नहीं हो रहा है. अरे भाई. Dr. Vibhuti, if you have time, then we can start from here.
Yeah. You please go ahead. We'll start from there.
ठीक है, हम यहाँ से start कर दो. उसका आवाज सब करना पड़ता है, स्क्रीन शेयर करके।
शेयर नहीं किया, शुरू से सेटिंग कर देते हैं, बड़ा कर देते हैं। साउंड ठीक है ना सर उतना?
करो शेयर ऑडियो, शेयर ऑडियो वीडियो करना, तुम ऑन रखो। आवाज आ रहा है? आवाज आ रहा है?
Yes.
आ रहा है ना?
It's coming.
Just before calling the participants for their presentation, I would just like to inform them that the marks out of 25 will be subdivided into few categories about the time management, originality and content, and their presentation. And the results would be sent by the judges to Sai Computers for Google Mark Sheet. Sai Computers it does the work for AIOS 2. And then the results will be sent back by Sai Computers to the judges, and then it will be announced by our Honorable President, Dr. Halimuddin sir. So now I will call the first speaker, Dr. Abhishek Kumar Sinha, to start with his presentation.
So timer on. I will request you to on the timer also. I am doing it.
Okay.
Start.
Good evening, everyone. I am Dr. Abhishek Sinha, and my topic for presentation is the prevalence of retinopathy of prematurity and relationship with various factors among infants admitted in SNCU RIMS contributing to screening programs. My mentor and guide is Dr. Rahul Prasad. Retinopathy of prematurity is a proliferative retinopathy, which is common preventable cause of blindness in preterm infants. Detection and treatment is important as its progression is very quick. In developed countries, ROP-associated blindness is reported to be lower than 10%, whereas in middle-income countries, the incidence is high, reported to be greater than 40%. In this study, we analyzed the incidence of ROP and aimed to contribute to the screening programs. Approval was obtained from the Ethics Committee for the study, and the study conformed to the tenets of the Declaration of Helsinki. In this study, we had 182 Am I audible?
Yes, you are audible. Please go ahead.
Yes. Good evening, everyone. The topic for today's presentation is.
You start from the left.
Okay. We had 182 premature infants who were admitted in SNCU between 1st April 2020 and 18th October 2020. with a gestational age of less than 37 weeks, and the examination was done using 20D lens and indirect ophthalmoscopy. Exclusion criteria included lethal congenital anomalies, death or loss to follow-up before complete retinal vascularization developed, and incomplete screening procedures. ROP was classified according to the international classification, and screening procedure was designed according to the suggestions of American Academy of Pediatrics, American Academy of Ophthalmology, and American Association for Pediatric Ophthalmology, and Strabismus. Early treatment for ROP study results recommended treating ROP with laser photocoagulation in zone 2 and 3 cases, and in zone 1 and posterior zone 2 cases with anti-VEGF. Infants are classified in 4 groups according to gestational age and into 8 groups according to birth weight. Data analysis was conducted using SPSS 20.0, and chi-square test was used to analyze the qualitative variables. Difference of P less than 0.05 was considered significant. Out of the 182 premature infants, 105 were female and 77 were male. The mean gestational age was 32 plus minus 2 weeks, and mean birth weight was around 1575 plus minus 500 grams. Overall incidence of ROP was 35%. 36 infants at stage 1, 7 infants at stage 2, 14 infants at stage 3, 2 infants at stage 4 and 5 of the disease, and 4 infants at aggressive posterior ROP. Mean gestational age who had any stage of the disease was 30 plus minus 2 weeks, and mean birth weight was around 1263 plus minus 400 grams. The incidence of ROP in female and male infants were 39 and 29% respectively, and hence there was no significant difference between genders. P value was 0.065. The incidence of ROP with gestational age less than 28% was 100%. 28 to 31 weeks was 63%, 32 to 34 weeks was 15%, and 35 to 37 weeks was 13%. This graph shows the incidence of ROP with respect to gestational age. We see that less than 28 weeks, that is very preterm babies, the ROP incidence is 100%, and it gradually decreases as the gestational age of the baby increases. In graph 2, we see the incidence of ROP with respect to age, and graph 3, we see the ROP with respect to birth weight. In this, we see that when the birth weight is less than 750 grams, the ROP incidence is about 100%. Then it gradually decreases. This table shows the features of kids having ROP and ROP positive and ROP minus infants. Table 2 shows ROP and its association with respect to gender, gestational age, and birth weight. ROP is a preventable blinding disease. Although diagnosing and treatment methods have been developed, it is still a threat to all premature infants all over the world, especially in middle-income countries like ours. Detection and treatment with screening program are very important to prevent poor vision. For screening program, detection of risk factors and incidence of ROP are essential. There are several risk factors for ROP, but birth weight and gestational age are the most important risk factors. In our study, the overall incidence of ROP was 35%, and incidence at any stage of ROP was 100% with gestational age less than equal to 28 weeks. We also found that the incidence of ROP with birth weight less than 750 grams was 100%. Our city nearby areas are less.
1 minute left. 1 minute left. Continue, please.
Yes, ma'am. So the other reasons for this high incidence of ROP may be low prenatal care, delivery care, and poor postnatal care standards. Screening criteria is usually based on gestational age and birth weight. Several screening programs have been done to create the criteria for ROP screening programs. These programs differ from one country to another and change from time to time. Limitations. The study has some limitations. First of all, the population is small and was conducted in RIMS Ranchi only, so the results may not reflect the true incidence of ROP in the whole of Jharkhand. And we conclude that ROP is still a incidence varies between countries and change from time to time. Rating criteria for ROP must be emphasized, and neonatal health conditions should be improved. As they say, early treatment, early diagnosis and treatment of ROP is important, and is then lost. Thank you.
Yes, on time.
We have 4 minutes for the judges to interact with the speaker.
And one more thing that we had requested them in the rehearsal time that you have to put on the rehearsal mode, but Dr. Abhishek did not put. So we request all the speakers, all the participants to put on that rehearsal mode so that the, on the screen the clock is seen, timer is seen.
Am I audible?
Yes,
Yes,
sir, you are
yes.
audible.
I think Dr. Abhishek, fantastic presentation and good compilation of data. But I would like to ask a few questions. So in your case series, almost we are about more than 28% of babies having more than 32 weeks of gestational age, which is not matching with other criteria. So 29% of your babies having more than 1800 grams birth weight, more than birth weight. So how do you explain that?
Sir, please repeat your question. I did not comprehend
My
what.
question is very specific. Almost near about 20 or 30, close to 30% of your babies are more than 32 weeks of gestational age and more than 1800 grams of birth weight. So how do you explain your case series, which is not matching to the international or other areas?
Sir, we in this COVID era, sir, we had examined very less babies, sir, and the studies from 1st April to 18th October only. So whatever babies we had for screening, we did the screening and we gathered the data, and whatever data was, we just jotted it down.
What is my question is, what is your possible explanation of this? Why the more mature babies are getting affected?
Sir, more mature babies, sir, the risk factor for ROP is like if we do not just monitor the oxygenation levels, and if the oxygenation level is more than 95%, it is a trigger factor for the ROP. So when the lung is not developed and the baby is born and it is on oxygen, the baby is on oxygen, and sir,
well taken. So one is more concentration of oxygen is being maintained. That's what you have mentioned there, poor postnatal care. So we consider it is as a poor postnatal care.
Yes, sir.
Correct. Okay. Any judges is having any other question?
Partha, you have to unmute yourself.
Yeah, so very nice study, Abhishek, and congratulate you for doing this. So
Thank you so much, sir.
As you have very rightly said, that this does not represent the Jharkhand state.
Yes.
So number of limitations that you have in your number, do you think that you could predict what number of premature babies could be a possibility in the state of Jharkhand?
Sir, it can just give a gross idea that most probably if a baby the only significance that I personally I am the JR1, so I thought that the most significant is that the babies having like less than 28 weeks or the babies who have a weight of less than 750 grams, all of them had ROP, nearly all of them. And this study is very small and we have only 182, we had only 182 children in which we completed our screening. So we saw that, sir, this cannot represent the true incidence of ROP in Jharkhand in any gestational age.
Right. Second question that I have in mind is the treatment that you could afford. What were the babies that you could not treat because of dearth of facilities, which is possible? Definitely not every center can have all treatment modalities, but what are the babies that you could treat and what are the babies that you could not treat? And of those babies whom you could not treat, how many could you refer and successfully refer to a higher center?
Sir, in zone 1 ROP, we give anti-VGF. This anti-VGF facility is available in our unit. So we advise the patients to take anti-VGF whenever we find zone 1. In zone 2 and zone 3 ROP cases, sir, we go for laser photocoagulation. For laser photocoagulation, sir, we refer to higher centers. And then, sir, the most of the patients are from lower socioeconomic strata, so we lost the follow-up. Mostly we lost the follow-up.
So why I asked you, Abhishek, is the importance and the pertinence of your study, which should actually be a marker for our NGOs or our government agencies to take up the ROP at all the levels of treatment.
Of course,
is the reason I asked you this. Thank you.
Thank you so much, sir.
Most important is that the data should have, your data should have some amount of the value which you can add to the, contribute to the treatment protocol or planning, or if not collecting a data is not a, not the end of your study.
Yes, sir. Yes, sir. Of course, sir.
Very nice study, Abhishek. Good study.
Thank you, sir. Thank you so much, sir.
So we go to the next speaker, is Achal Priya. She will be presenting about risk factors for persistent or recurrent CSCR. Please share your screen, Dr. Achal. Speakers should be ready with their presentations so that.
Dr. Bibhuti, can you just tell us once more about the which are the heading we are just marking? Originality, presentation.
The time, how well they stick to the time, and
Content,
presentation, time management, originality, and content.
Okay.
Analysis, I think.
content, reality, मैं बता रही हूँ.
Okay.
Time,
मैम ये
पढ़ो क्या? हाँ पढ़ो.
ओरिजिनलिटी, इनोवेशन, कंटेंट एनालिसिस और प्रेजेंटेशन एंड
दिख ही नहीं रहा है. Yes. Originality, content, analysis, innovation, and presentation time. Am I audible?
Yeah.
Okay.
You start your presentation, Dr. Achal.
Okay. Good evening, everyone. My topic is risk factor for persistent or recurrent central serous chorioretinopathy under the guidance of Dr. Sunil Kumar sir. Central serous chorioretinopathy is a common macular disease characterized by presence of well-circumscribed serous retinal detachment in the macular region with one or severe leakage points at the level of retinal pigment epithelium. Acute CSC is typically a self-limiting disease with good visual prognosis, while a recurrent or chronic CSC may develop IP atrophy and neurosensory retinal changes that result in permanent visual loss. Aim of my study was to assess the risk factor for the persistent or recurrent CSC. This was an observational study of 50 patients with clinically diagnosed CSC. Patients were divided into two groups. First, in those with acute CSC with spontaneous resolution of subretinal fluid within 3 months or no recurrence within a year. And second group with persistent SRA for more than 3 months and the patient with recurrent episodes. All these patients were asked to complete questionnaires which included previously described risk factor for development of CSC like male sex, age, history of hypertension, tobacco use, allergy disease, depression, stress, and the sleep disturbance. All these patients were monitored with optical coherence tomography every 4 weeks for a year. This is the insomnia severity index we use for the assessing the severity of insomnia. It has 7 questions and total scoring of 28. Score of more than 7 is clinically significant insomnia. The data was analyzed with SPSS 21.0. The calculated values were presented as frequencies, mean, and standard deviation. P-value less than 0.05 was taken to be significant. In my study, a total of 60 eyes of 50 patients were included in the study, in which 20 patients were acute CSC and 40 eyes with recurrent or persistent. The mean age for recurrent or persistent was 47.1 plus minus 6.64 years. As compared to acute, the mean age was 38 years. P was significant, 0.009. The male is to female ratio in persistent or recurrent cases were 4:1. P value was significant, 0.0032. High insomnia index, severity index was present in recurrent cases. This was the analysis of the risk factor. Male sex, older age, history of hypertension, more than 5 years, use of tobacco, and ISI score more than 7 was more significant in persistent or recurrent cases of CSC. Early studies by Chatzirali reported that MIL6 is an independent risk factor for the recurrence or persistent CSC. Study by Halimuddin reported that women with CSC tended to have better outcome than men. This suggested that CSC might be associated with male-specific steroid hormone, that is testosterone. Testosterone is a vasodilator that causes choroidal thickening, as it is choroid is highly vascular organ. Previously, studies shows that age is an independent risk factor for persistent or recurrent CSC. This is due to lost barrier function of RPE and that leads to leakage of fluid from choroid to subretinal spaces. Earlier studies reported that sleep disturbance is significantly more frequent in patients with CSC. Sleep disturbance have been associated with altered secretion of catecholamine and cortisol hormones. These two hormones are implicated in the pathophysiology of CSC. In our study, we showed that high ISI scores were independently associated with persistent or recurrent CSC. This study shows that male sex, AS, and sleep disorder are the risk factor for persistent or recurrent CSC natural history, and this patient may require early photodynamic therapy. All CHC patients require careful and periodic follow-up. These are some references for the risk factor and the risk factor for recurrence of CSC. Thank you.
Okay.
Nice presentation, Dr. Achal. I request the judges.
Dr. Achal, it's a nice presentation and good collection of data. But did you have done the baseline steroid level estimation?
No, sir.
Early morning cortisol level steroid estimation, because only insomnia may not be directly related to that. So what you are trying to explain is due to insomnia, the steroid level is increasing, and that's how is happening. So if it is the stress and anxiety level, so that should have been correlated with your 8 AM cortisol level estimation. Number one. Number two is what is your any OCT, choroidal OCT picture, or any ICG angiogram and fluorescein angiogram correlation is there or not? Because if you are telling about this is the steroid induced or whatever reason there is a insomnia, that's what insomnia you are putting. Male factor is what we all know, but again insomnia, that's what you are trying to re-emphasize, isn't it, with your studies?
Yes, sir.
Yeah. So steroid correlation or the pachychoroid or the choroidal thickness, do you have any correlation with that? So then you can establish your fact. Third factor is that in Indian population, majority of the chronic CSR or the recurrent CSR, a major variety, almost 40 to 50% is actually a polypoidal choroidal vasculopathy disease. So unless and until we do ICG angiogram, it is difficult to detect whether we are actually dealing with CSCR or another disease. So probably that correlation would have been giving you a much better result.
Sorry, sir. I can't hear you.
Yeah, and ICG angiogram and correlation to rule out the presence of PCV, polypoidal choroidal vasculopathy, that will give you probably a better result and outcome, and the value of the study will increase further. So if you can go back and look into those factors also, we'll have a great value. Thank you.
Okay, sir. Thank you.
Nice presentation, Achal. And one small question which is relevant to all presentations is that what does your study give in particular to the other studies that you're compared with, which shows that there is some importance of the study to our current understanding of CSR? Anything specific that you have been able to elucidate? Or is it comparable in total to all the other studies that have been done so far, the ones that you alluded to? ऐसा कोई फैक्टर आपके स्टडी से आया है जिसको आप ये बोल सकें कि ये इसलिए हमारा स्टडी यूनिक है, ये एक यूनिक कुछ आप ला सक रही हैं. So can you say anything like that?
Sir, in our study, we mainly focus on the insomnia cases, but there are some study which include that topic, ISI scoring.
So that Dr. Rupak has just told about the importance of the ICG and the other factors that can be taken up as well. Right. Okay, Anchal. Thank you.
Thank you.
I think Dr. Antaba is ready with his presentation. Dr. Antaba, you can unmute yourself and share your screen. Next speaker is Anupama, so she should also be ready with her presentation after Antaba.
Dr. Bibhuti, can I ask a question to Dr. Rupak?
Yes, sir, please go ahead.
Dr. Rupak, tell me.
You are muted, sir.
Archel had a paper. The Archel has a paper in which she says that she had 60 cases in 50 patients. It means there is in at least 10 cases it was bilateral. To me, it seems to be it's not very common to have a bilateral CSR in patients, and that in a very short span of time. Just want to have your opinion. Nothing to do with this paper.
Yeah. So that's what I was focusing on that. If you have a PCV, polypoidal choroidal vasculopathy, so those cases are having a very high chance in Indian population is a bilateral involvement. And chronic CSR, they present like a chronic CSR because unless and until you treat those polyps, and even if you treat those polyps, if you have a fusiform dilatation of those blood vessels, they can leak. There is a boggy swelling of the choroid and leads to CSR. Whenever they go into a stress factor, like it is already a dilated blood vessels, and when they go into the stress, the steroid level increases, hyperthermic circulation increases, and they causes more amount of the leakage. So that's how even the basic mechanism of polyp also comes from there. So probably the bilateral involvement is usually due to the polypoidal involvement. So
even for the
go back and see.
Even for the PCV, having a bilaterality is not very common.
60%. Indian population, around 2/3 of them are having bilateral involvement.
Right.
And in her series, only 10 patients out of 10, 50 eyes, 60 eyes of 50 patients. So that means 10 patients have the bilaterality.
Thank you. Thank you.
Thank you.
Sir, Dr. Antaba, you share your screen.
Good evening, everyone, to all the senior doctors, and I am thankful to JHOS committee for giving me a platform to present today on my topic: comparison of recurrence rate after using mitomycin C intraoperatively versus conjunctival autograft following primary pterygium excision. And I have been guided by I have done the study under the guidance of Dr. Rahul Prasad sir. Pterygium, a ring-shaped fibrovascular subepithelial ingrowth of elastotic degenerative bulbar conjunctival tissue over the limbus onto the cornea. Etiology, it's not definitely known, but more common in people living in hot climates, probably as a response to prolonged effect of ultraviolet exposure, chronic surface dryness, or some other reasons. Clinical features include demography, that is age usually in old age, more common in males, and maybe unilateral or bilateral, and usually on nasal side. Symptoms, mostly asymptomatic in early stages. Cosmetic intolerance may be the only issue. Sudden body sensation and grittiness may be complained by the patient. Defective vision due to encroachment onto the pupillary area or due to corneal astigmatism. Occasionally, diplopia may be present due to restricted ocular movements. In case of pseudopterygium, history of trauma, chemical burn, or any inflammatory episode must be noted while taking the history. Signs. The parts of a fully developed pterygium include cap, head, and body. Progressive pterygium is thick, fleshy, and vascular. First sides, eyelets in front of head of pterygium is noted. And in regressive pterygium, thin, atrophic, and attenuated pterygium is noted, stalkus line anterior to head may be present. It is due to the deposition of pseudopterygium distinguished by etiology, site, and protest. Complications of the pterygium can be cystic degeneration and infection. An infection is infrequent, rarely epithelioma, fibrosarcoma, or malignant melanoma. Treatment includes medical treatment, topical lubrication, or any anti-inflammatory agents, use of sunglasses, surgery, simple excision, bare sclera technique, but it has very high recurrence rate. Simple conjunctival flap can also be used, but conjunctival autografting, usually from superior temporal paralimbal region, is most commonly preferred. Amniotic membrane grafting followed with sutures or tissue glue is also used nowadays. Adjunctive treatment with mitomycin C or beta irradiation have also been developed. Peripheral lamellar keratoplasty for deep lesions is preferred. Mitomycin C is an anti-neoplastic drug selectively inhibiting the synthesis of DNA, cellular RNA, and protein, thus affecting cellular proliferation for a long time. Can be used preoperatively, intraoperatively, or postoperatively. Single preoperative use is safer than pre and post-operative application. Conjunctival autografting has better healing of the conjunctival tissue and barrier to fibroblast proliferation. Also better cosmesis post-operatively. Only disadvantage is technically more demanding and time-consuming. These are the because of progressive and regressive pterygium. Aim of the study: to compare the recurrence of the pterygium following the intraoperative mitomycin C application and the conjunctival autograft after primary excision. The method used is randomized clinical study in total 100 patients with primary pterygium from June 2019 to September 2020 in Riorim, Ranchi. Exclusion criteria was recurrent pterygium, scarring, or dry eyes. Patients were examined in details and divided into two groups, Group A and Group B. Group A received 0.02 mitomycin C on bare sclera, and in Group B, conjunctival autograft was sutured to bare sclera using 80 week rate. Data collection and analysis for recurrence rate was done. Subconjunctival antibiotic and steroid given to all patients and iPad applied for 24 hours. Post-operatively, topical antibiotic steroid combination was given for 6 weeks. Follow-up was done on day 1, week 4, and week 12. At each visit, patient examined for corneal and conjunctival wound healing, and any sign of recurrence was noted. All surgeries were done by single operating surgeon. This is a picture of preoperative primary pterygium. Then the second picture is pterygium excision followed by conjunctival autograft. And this is a picture of 3-month follow-up that same patient of right eye pterygium surgery, post-right eye pterygium surgery. This is a picture of mitomycin C application on a patient following pterygium excision. Results: out of 100 patients operated, 60 male and 40 were female. Age ranged from 30 to 60 years. Mean age was 45 years. Right eye was affected more. That is, in 56 patients, right eye was affected, and in 44 patients, left eye. Thorough preoperative workup and visual assessment, refraction, anterior and posterior segment examination was done. No intraoperative complication noted in either group. As we can see the table, the data we collected is recorded in this table. In Group A, pterygium recurrence was seen in 5 patients, that is 10%. Ocular irritation experienced by 15 patients, that is 30%. Graft retraction was seen in 5 patients of Group B, that is 10%, and 4 patients of Group B had persistent redness over the grafted tissue. Pterygium recurrence was noted in 3 patients, that is 6%. The donor site healed smoothly at its own. Sutures were removed at second post-operative follow-up in all patients. Patients with intraoperative mitomycin C showed greater recurrence than those received conjunctival autograft. Study was done to establish a procedure with minimum recurrence and better cosmesis following primary pterygium excision. Male preponderance was in more than females. Conjunctival autografting, as we can see, that first described by Kenyon in 1985, and recurrence rate of 5.3% was noted. In our study, recurrence rate of 6% was noted. Mitomycin C in single intraoperative dose is safer. Complications due to high concentration or prolonged duration of MNC application can be scleromalacia, corneal perforation, glaucoma, iritis, and punctate keratopathy. In our study, recurrence rate of 10% was noted with mitomycin C. Both mitomycin C and conjunctival autograft are effective in lowering the recurrence rate of pterygium, but conjunctival autograft has comparatively lower recurrence rate than mitomycin C and also gives better cosmetic results. But the only drawback with congenital otography is that it is technically more demanding and the time taken in the procedure.
15 seconds.
This is a video, just in a short, how we are excising the pterygium tissue. First, we are instilling the, injecting the local anesthetic.
Your time is up, beta.
Okay, ma'am.
It's over.
This is a surgery.
Seven minutes over.
Let's have.
Thank you, ma'am. Thank you so much, ma'am. Thank you, sir. Thank you, respected doctors.
Over to the judges.
Nice presentation and good analysis of your results. What we definitely did is in your case, the MMC recurrence was definitely much lesser than what is reported in the literature, is it not? It's nearly half. 20%, 25% is what is reported in the literature, whereas in your case, it was in your series, it was just about 10%. And that again does not become very highly statistically significant when you compare it with the CAG, right? So any thoughts about this? Why was there such a large difference between other studies and your study?
Sir, it also depends, thank you sir for the question, sir. Sir, it also depends upon, sir, how we are applying the mitomycin C and for what duration we are applying the mitomycin C over the bare sclera. For example, if, for example, in most of the cases, it should be applied around 4 to 5 minutes like this over the bare sclera. If we apply it for just a few seconds or just 1 minute or 2 minutes, depending upon the how the surgeon feels comfortable or like that, then depending on the duration also and depending upon the patient, the mitomycin C effect also takes place, and depending upon that, recurrence takes place.
Antab, then answer specifically,
Yes,
how is the difference between the exposure time in the different studies? Did you assess the difference in the exposure time to the recurrence from your study to the other studies?
No, sir, because it couldn't be assessed that much accurately, sir, in the study.
Okay. What was your exposure time to MMC?
Sir, it varied. Actually, exactly 4 minutes we couldn't do. But for example, for in some patients, 3.5 minutes, and in some patients 4 minutes, and in some patients more than 4 minutes like that. Just it varied from 3 to 5 minutes, sir.
Right. Right. Okay.
Thank you, sir.
Okay, so should we move to the next speaker? Dr. Anupama, are you ready with your presentation? Dr. Anupama will be presenting impact of COVID-19 on ophthalmology department of RIO RIMS, Ranchi. Dr. Anupama, you share your screen. Speakers have to be careful. The moment they start their screen, the timer will start.
Because actually I'm not able to share my screen.
Did you practice? You were practicing that time it was coming?
Yes, sir. That time, yes, ma'am. That time it was showing, but right now it's not showing, ma'am.
I think make your screen smaller. You'll find the screen share screen tab.
Ramanji, are you?
Share screen tab is there, and then if your presentation is on the desktop,
They have rehearsed.
Keep your desktop presentation open. Yes, that's it.
Okay. Yes, now
it's okay now. Is it visible now?
Yes.
Yes, yes. Go to the presentation mode.
Okay.
Slide.
A very good evening to all the respected doctors. I am Dr. Anupama, and today I'll be talking on the impact of COVID-19 on the ophthalmology department, that is our RIO RIMS. Before I begin, just a brief review of COVID-19. It is a viral infection caused by severe acute respiratory syndrome coronavirus 2. WHO has declared it to be a global pandemic on 11th March 2020, and India is the second worst affected country in terms of total number of infected patients, just next to USA. The most common mode of its transmission being droplets, close contacts, and aerosols. It has affected almost all sects of population, and ophthalmologists are no exception. It has got great impact on ophthalmologists as they are at higher risk of infection due to routine face-to-face clinical examination as we do in slit lamp examination or direct and indirect ophthalmoscopy. According to some reports, ophthalmologist practices have suffered the worst among all other specialities as majority of ophthalmic surgeries are elective and majority of ophthalmic patients are elderly with multiple comorbidities. It has also affected the ophthalmology residency training program. With all these thoughts in my mind, the aim of my study was to study the impact of COVID-19 on ophthalmology department, that is RIO of TRIMS in terms of patient load, their age and sex distribution, and the number of surgeries performed. In material and method, my study is a hospital data-based retrospective observational study for a duration of 1 year, that is from October 2019 to September 2020. That includes 6-month period pre-COVID, that is October 2019 to March 2020, and 6 months period post-COVID, that is April 2020 to... Is it visible to all of you?
Yes, yes. Carry on.
Okay. And 6 months post-COVID, that is from April to September. Evaluation were taken up for the study. All the guidelines and protocols for safe ophthalmic practices laid down by Ministry of Health and Family Welfare, Government of India, like screening, universal masking, safe social distancing, frequent hand sanitization and sanitization of the surfaces were followed. This is how we did at our center. Coming to results, the total number of patients attending OPD from October 2019 to March 2020 were 17,315, and that number went down to 2,268 from April to September 2020, which marked a decline of 86.9%. On an average, earlier 3,000 patients per month used to attend ophthalmic OPD of RIO RIMS, and that number went down to less than 500 per month. In population distribution, males constituted the majority of OPD attendance, but the number of females attending ophthalmic OPD decreased from 36.14% to 27.69%. But an interesting finding came up in my study was an increase in the number of pediatric patients. Their number rose from 17.87% to 22.49%. In addition to all these, the number of patients getting admitted in our hospital also declined. Earlier, on an average, 170 patients used to get admitted in our eye ward, but that number went down to as low as less than 10 on an average. Subsequently, the number of surgeries performed also declined. A decline of more than 91.6% was noted in both the minor and the major procedures. Coming to discussion, there is significant decrease in the number of patients visiting OPD of RIO in Ranchi, more so of female patients, 36.14% to 27.69%, most likely due to lack of means of transportation during these difficult times, fear of getting infected by the virus, and lack of awareness among the local rural population. Hence, the number of surgeries performed has also gone down. Similar results were also seen in a study conducted at Apex Tertiary Care Ophthalmic Institute by Rinki Agarwal et al. An analysis of 2 million patients across 228 hospitals in 40 states of USA has also shown similar results. However, there was a significant increase in the pediatric patient in my study, as in contrast to the study conducted at Apex Ophthalmic Institute,
most likely attributed to their increased digital screen time, more of near work, and lack of outdoor activities. According to UNESCO, approximately 1.37 billion students, that is 80% of the world's student population from more than 130 countries globally, are affected by digital and e-learning approaches in these COVID times. A large cohort study of 5,074 children in Rotterdam have also found an association between increased computer use and myopia. Hence, I conclude COVID-19 pandemic has severely affected the functioning of ophthalmology department at RIO RIMS and also the residency training program. But thankfully, our professors and consultants have tried to streamline the academics by conducting weekly webinars. Backlog of preparations are expected to shoot up in the coming days, and so is our learning graphs. My take-home messages are COVID is here to stay. So we need to learn through our experiences to adapt to this new normal. And with all the necessary precautions, the process of learning and treating the patients must go on. These are all my references. Thank you.
Thank you, Dr. Anupama. So over to the judges.
Rupak? Okay, Dr. Anupama, very nice study done, and your analysis and the amount of analysis that you showed was very nicely graphically also recorded. Very good, very good. So I have one or two small questions for you. So since you have a good amount of data, especially at your tertiary center, there is no dearth of data. Like from October 19 to September 20, this was the study that you conducted. So my thought would be that if you could compare it to month, that is, if you could have extended the study period from, say, March, because March was when the time came when the COVID had come in, and then April, May, given a good analysis also month per month, because we all know that the ophthalmology patients, vary from month to month, the disease, the nature of their travel, etc., and the possibility of getting surgeries done is from month to month. So that could have been, could have added a little more strength to the study. The other thing that you have anything, to remark on this? I mean, this is a question that could you have done this, or?
Yes, sir, surely I could have done this, and that would have been perhaps more better. But actually, I joined here 4 months back, and then I came to know that here the patient load was not as such we are having now. That's why it came in my mind to start with the previous times and how the number of patients has varied and how the number of surgeries have came down.
Yeah.
Just that point was there in my mind.
The point is well taken. I mean, but you have records of the past as well. That's what I wanted to say. So month per month analysis would have been an extra strength to your study. The other thing about the pediatric population, very nicely highlighted by you, and the pediatric numbers increasing, the possibility is also at another angle maybe. The number of other diseases coming down could have actually been an effect on your pediatric numbers. Okay, so as the average of patients for others like cataract and other diseases have been coming down, so the number of pediatric population, there could have been an indirect increase of the pediatric population. So that is another thought. But it is very nice that you took this up and you afforded it to the screen time that was involved. So I would request you to continue your study and see the effect of screen time in your pediatric population, and you have a large number, and how their myopia or their refractive error has progressed over this, because it's been a long duration. And we all know that screen time and near vision activities actually can increase the myopia levels. So that is a good follow-up that you can think of. Good. I congratulate you for a very nice study.
Thank you, sir. Thank you. And I'll always try to do that. Thank you.
Our next speaker is Dr. Ashita. She'll be talking about the comparison of efficacy and safety of olopatadine 0.2% versus bepotastine bacillate 0.15% in patients with VKC. Dr. Ashita, please share your screen.
Yes.
Yeah.
Good evening all. First of all, I would like to thank JHOS for giving me such an opportunity. My topic is comparison of efficiency and safety of olopatadine 0.2% versus bepotastine 0.15% in patients with vernal keratoconjunctivitis. Nil financial disclosure. Aim to compare the efficiency and safety of olopatadine versus bepotastine in patients with vernal keratoconjunctivitis. Introduction. As all of you know, VKC is a recurrent bilateral interstitial self-limiting allergic inflammation of conjunctiva having a periodic seasonal incidence. It's more common in boys between 4 to 20 years. Symptoms are burning, itching, brownish discoloration of conjunctiva, photophobia, lacrimation, rocky discharge, etc. According to the science, it can be differentiated into 3 forms. That's palpable form. In palpable form, you can see the conjunctival hyperemia, macropapilla less than 1 millimeter, which resembles cobblestone appearance, and giant papillae, which is more than 1 millimeter. Then bulbar lymphoma, here you can see dusky red triangular congestion of bulbar conjunctiva and horned tanda spores. Mixed form, it is a mixture of this palpable form and bulbar lymphoma. And vernal keratopathy, which is the common involvement, includes superior punctal epithelial erosions, epithelial macroerosions, vernal corneal plaques, and ulcerative vernal keratitis, which is also known as shield ulceration. Treatment part, first line treatments are general measures, that is avoidance of allergen, cold compresses, etc. Then topical dual-acting antihistamines or mast cell stabilizers, non-sedating antihistamines, and treatment of coexisting allergic rhinitis. Second line treatments include short course of topical steroids and allergen immunotherapy. Third line treatments are topical immunomodulators like calcineurin inhibitors and omalizumab. Coming to the proper topic, olopatadine 0.2%. It is the first dual-acting anti-allergic drug to receive FDA approval as both an antihistamic and mast cell stabilizer. It can be used both as a therapeutic and prophylactic agent. Has higher efficiency, rapid onset, and longer duration of action. Its dosing is 1 drop twice daily, well tolerated in children 2 years and older. Most frequent side effects are dry eye, pruritus, and taste alteration. Bepotastine basically 0.15%. It's a newer anti-allergic agent with a multiple mechanisms of action. It is both it has both antihistaminic and mast cell stabilizing effect, and it also has this anti-inflammatory effect. That is, it inhibits the leukotriene B4 production and attenuating eosinophil chemotaxis and activation. Side effects are irritation, stuffy nose, and sore throat. Coming to materials and method, it's a prospective randomized comparative clinical study conducted in 80 patients of VKC between 4 to 16 years of age from March 2019 to March 2020. Each study group had 40 patients and had received either topical bepotastine or olopatadine. And clinical symptoms and signs were assessed in all patients at week 0, that is the baseline, week 4 and week 8. Come to clinical symptom scoring. Clinical symptom scoring was based on 5 symptoms, that is itching, watching, redness, rocky discharge, and photophobia. And a 4-point scale was introduced, that is grade 0 no symptoms, grade 1 mild symptoms, 2 moderate symptoms, and grade 3 severe symptoms. And the total score is from score 0, that is asymptomatic, and to 15, that is very symptomatic. There is 5 symptoms into 3 maximum score, that is the maximum score 15. A reduction in the score with treatment was considered significant. Coming to clinical sign scoring, it's similar to clinical symptom scoring. Signs used were conjunctival hyperemia, mucous discharge, tarsal papillae, tanda spores, and corneal involvement. Coming to the result, was clinical symptom score analysis. Table number 1 showing intra-group comparison in olopatadine group. Baseline score was for 7.20, it reduces to 5 in week 4, that is 30.55% reduction. In week 8, it reduced to 2.20, that is 69.44% reduction. That is, we found a statistically significant reduction in clinical symptom score when compared to baseline for at week 4 and week 8. That is, p-value was less than 0.001. In intragroup, table 2 showing intragroup comparison in group B, the baseline score was, that is bepotastine group. Baseline score was 7.8, it reduced to 5.40 in week 4.
There is 30.76% reduction. In week 8, it is 71.79%. Here also we found a statistically significant reduction in clinical symptoms when compared to baseline. In intergroup comparison, we cannot find a statistically significant difference in reduction between these two groups. In graph, you can see in week 8, the score was almost same in olopatadine and bipotestin groups. Coming to clinical signs scoring, table number 4 showing intergroup comparison in group A, that is olopatadine group. Baseline score was 4.10, it reduced to 2.50. In week 4, there is a reduction of 39.02% and week 8 reduced to 71.21%. There also found a statistically significant reduction in clinical signs in week 4 and week 8 compared to baseline. In table number 5 showing intergroup comparison in bipotestin group, the baseline score was reduced to 37.20% in week 4 and 72.09% in week 8. Again, a statistically significant reduction in clinical signs score in week 4 and week 8 comparing to baseline. But in intergroup comparison, we cannot find a statistically significant reduction in clinical signs score. That is, p-value was more than 0.05. In graph, you can see in week 8, the clinical signs score was almost same in two groups, that is olopatadine and bipotestin. That is, in the study for clinical symptom scoring, bipotestin basically showed better response than olopatadine. For clinical signs scoring, the maximum reduction of signs at 8 weeks for bipotestin was 70% and for olopatadine was 71%. However, there was no statistically significant reduction difference between two treatment groups at 4th and 8th weeks, and none of the groups showed any serious side effects. Discussion. Both the study groups have statistically significant reductions of scores at 8 weeks, and in both study groups, the significant reduction occurred at 4 weeks, indicating a similar onset of action and clinical improvement with the two drug groups. During subsequent visit, there was a gradual further decrease in symptom and sign score, indicating that the improvement was sustained throughout the study period without loss of efficiency. In this study, bipotestin basically showed better response than olopatadine at 8 weeks. However, there was no statistically significant difference between the two treatment groups, at 4th and 8 weeks.
Time is up. Time is up.
Both are equally effective in reducing clinical symptoms and signs of weakness. Both of them were well tolerated without any serious adverse effect. Thank you for your patience.
Very nice presentation, Dr. Ashita. Over to the judges, please.
Very nice, Ashita, and congratulate on your good analysis that you have done. It was a prospective study, very nicely laid out as well. One thing that I thought, since it was a prospective study, you could have also made it a double-blind study, right? That would have added strength to the study itself. That is number one. And the other thing that could have again increased the strength of your study is, had you done it in the contralateral eyes, the one eye bipotestin and the other eye olopatadine. So that would have given huge strength to this study, and it would have increased the originality as well as the analysis of your study. Then you are comparing one eye to the other. If it was a double blind, again, that would have given a lot of importance to what you actually find and the follow-up of the patient. So what do you think of this? Do you think that what I'm saying?
Yes, sir.
Okay. Rupak?
Yeah, fine. Go ahead.
So, but overall, very nice presentation.
Yes. It's fantastic.
Thanks, sir.
So we move on to the next speaker, Dr. Bibhuti Kashyap. He'll be presenting a paper about failed vitreoretinal surgery, a new indication for endo-illuminator-assisted scleral buckling. Dr. Bibhuti, please share your screen.
Good evening, everyone. Is my slide visible and am I audible?
Yes. Yeah. Go ahead.
Right.
Yeah, please go ahead.
Good evening, everyone. So my topic is a new indication for endoillumination assisted scleral buckling, or EASB, that is failed vitreoretinal surgery. Now, current world literature is filled with publications that focuses on limitations of scleral buckling surgery and how vitrectomy is the option when a scleral buckle fails or is not feasible. With current advancements in technology, vitrectomy has an edge over scleral buckling in terms of surgery of choice for primary reg RD. Now, with current technology of endoillumination, the status of scleral buckling has somewhat been revived because it overcomes the issue of visibility that comes with an extraocular procedure. Repeat intraocular procedures has its own set of challenges and complications. The question then arises that with the help of endoillumination, can scleral buckling turn the table on its head, and can this old albeit safer procedure come to rescue of the failure of a modern vitreoretinal surgery instead of the usual way of it being the other way around? Upon literature search, there was no published reports about the surgical outcomes of EASB in silicone oil filled eyes with failed vitreoretinal surgeries. So our aim was to evaluate the surgical outcomes of EASB in eyes with failed vitreoretinal surgeries with oil filling. It was a prospective interventional case series of 6 months with 15 eyes of 15 patients. Baseline characteristics of age, etiology, time since last surgery, pre-op vision, lens status, and PVR grade was noted. All patients underwent a non-drainage EASB. And the follow-up was on the first day, 1 week, 1 month, and at 3 months. And the vision, retinal status, intraocular pressure, and lens status were recorded. Patients included in the study were the ones having retinal redetachment after vitreoretinal surgeries with a silicone oil-filled eye, without any visible break, and with a PVR grade less than or equal to C2. Patients excluded were the one with the history of use of encircling band or tiles, with the history of use of gas tamponade, presence of a posterior causative break or fixed fold, or pre-existing glaucoma or media opacity. The procedure was performance of a 360-degree concaval peritomy and isolating the red eye and hooking them up with cotton sutures. Fixing a chandelier endoilluminator, and a try of localizing the break was done under the contact wide-angle viewing system. This visualization was hindered by the blood meniscus under the lens, as well as by the optical hindrance caused by the intervening oil meniscus. But careful maneuvers, obviate these difficulties, and a causative break is usually localized. Cryopexy is applied to this break. A 276 number scleral buckle or scleral tire is support the break. Followed by an encircling band. The conjunctiva is then closed in a ship-to-show manner. So our results were 40% of the patients in the study were females and 60 were male. 65% patients in our study were phakic. The median age of the patients was 48 years, and all patients had undergone vitreoretinal surgery with silicone oil injection for primary RD. The mean time lapse since last surgery was 26 days. 4 patients, that is 33% patients in our study were one-eyed. Intraoperatively, 1 patient was found to have a fixed fold, 1 had a posterior causative break, and 1 patient had a significant lenticular opacity that precluded break visualization under even endoillumination, and these were converted to an intraocular procedure. The retina was attached on day 1 in 92% patients, that is 11 out of 12 patients that underwent EASB. Best corrected visual acuity significantly improved. Intraocular pressure showed no significant variation pre-op versus post-operative till the 3rd post-operative month. There was no significant change in the silicone oil meniscus height post-surgery when evaluated clinically, and no patient developed endoilluminator site-related break or cataract at 3rd month follow-up. This is an example of an eye with retinal redetachment treated successfully with endoilluminator assisted scleral buckling. So EASB basically enables an extraocular procedure with ease by circumventing the difficult visualization of small pupil, posterior capsular opacification, silicon oil meniscus, retinal holes in myopic eyes, and peripheral small breaks in pseudophakic eyes. And by virtue of being majorly an extraocular procedure, circumvents the intraoperative challenges of a repeat intraocular procedure, like performing a retinectomy or retinotomy, accidental suprachoroidal air, choroidal detachments, intraocular bleeds, creation of an iatrogenic break, etc. It's a safer choice in patients where a repeat intraocular procedure can be detrimental to vision. That is, in patients with high myopia with vitreous schisis, in one-eyed patients, patients with history of keratoplasty who has to undergo repeat via surgery, aphakic patients, patients with unstable lens or IOL. The possible rate-limiting factors in patients who qualified our inclusion criteria were availability of a trained assistant for holding a contact wide angle, interfering blood meniscus, and optical hindrance by the silicon oil meniscus upon indentation. The limitations of this study was a smaller sample size and the performance of a non-drainage surgery instead of a training one. So EASB obviates further intraocular manipulations and its associated complications in an already vitrectomized eye. Hence, it is a safer choice than a repeat intraocular procedure in eyes where a considerably anterior break is the cause for retinal redetachment. But despite limited sample size, the success rates are encouraging enough for it to be soon used as a standard protocol in select cases. And like COVID-19, EASB for retinal redetachment may soon also be a new normal. But these are my references. Thank you so much.
Thank you, Dr. Bibhuti, for your presentation. Over to the judges.
It's a fantastic concept, Dr. Bibhuti. I must congratulate you. It's a fantastic concept.
Sir, am
I audible?
Yes, Rupak, you are audible now.
Okay. So there are 2-3 questions to you. So did you put only encyclic band, or you have the buckle segment also did you put?
Your voice is cracking, Dr. Rupak. It's not very clear.
What is asking Bibhuti is whether
I cannot hear anything. Everything was blanked out. I don't think the connection is too good.
What Rupak asked is whether you put only an encerclage band or whether also you put a buckle. In your case.
Sir, I'm not able to hear. I think there's some problem with the connection.
Dr. Bibhuti, can you hear me? I'm Dr. Bibhuti Bhushan. Can you hear me?
Rupak,
no, sir,
why don't you try and talk to him once more? Rupak?
Yeah. Am I audible to other people?
Yeah, we can hear you, Dr. Rupak.
I think.
Yeah, now I can hear you.
Yes.
We still have time.
Go ahead, please.
Yeah, the question is that
no, nothing.
इंटरनेट का प्रॉब्लम से सॉल्व करो.
Did you put only band?
बोल के भी नहीं कर सकते हैं.
Or did you put only segmental buckle?
Sir, everything is. I don't think my connection is going good.
We can
it is showing red. Your connection is showing red here.
Your voice is clear, Dr. Bibhuti. We can hear you.
What you can, Bibhuti, you can.
I can come to Dr. Bharti Kashyap's window if that is fine. If you can give me the just.
Yeah, that's.
Yeah,
fine.
I think then that's fine.
Hello.
Hello.
Dr. Bibhuti, you can come to my window.
Please use another window.
Bibhuti?
Please use another window. उनको जाके बोलो कि दूसरा विंडो यूज करेंगे.
So one of the drawbacks of Zoom.
Come. Go. Video on.
Yeah, he has gone to Dr. Bharti's window. Yeah.
वहाँ जैम हो गया. वहाँ freeze कर गया.
No, I'm able to hear. Please, yeah.
Rupak, go ahead. Rupak?
It's jammed here as well, I think.
Rupak, are you there, Rupak? Anyway, I'll repeat Rupak's question. Rupak,
Yes, sir.
Okay, Rupak is here. Rupak, unmute yourself.
Dr. Rupak, you are muted.
Rupak,
Dr.
unmute.
Partha Biswas, if you can repeat the question what Dr. Rupak wanted to ask.
The question what Rupak wanted to ask is, in your cases, did you put an encerclage band only, or did you also put a buckle?
No, sir. In all the cases, the buckle was put, as I showed in this surgery. The buckle was essential along with the encircling band. The causative brake was in all the cases supported with a 276 number buckle, the tire.
Rupak, unmute yourself.
Mr. Raman, can you help Dr. Rupak unmute himself?
Yeah, I will try, but he himself, he has to do the mute and unmute, sir. I will try.
Rupak, unmute yourself, you know.
I think he has a fluctuating network.
Just a minute, bro. I'll just call him back. You're not able to unmute yourself?
His frame is also frozen actually.
Okay. Okay. You can. I can hear you, but then switch over to the other frame. He's connected to another one, so he's trying to come in.
Can you hear me?
Yes, sir.
I think now you can hear.
Yes, sir.
Yeah. So very good presentation, very good concept. Everything is fantastic. So the buckle segment, what you are putting is a nice concept. So 3 points quick. Have a significant SRF.
He has a bad network, sir.
Rupak,
He has a bad network, sir.
Rupak, what I suggest is switch off your video. Just be on the audio. That would be better, I think.
Yeah, I have done.
Right. What is the question?
Whenever you have a significant fluid, how do you manage by non-drainage technique?
Sir, exactly my point and exactly the limitation of this study as I discussed. There was one patient which had a significant amount of fluid which did not go by the non-drainage surgery. So that was my limitation, which when I performed the repeat intraocular procedure, the fluid that came out was very thick and old, but the quantity was more than what we normally saw in the other 11 successful cases. So that is one drawback of this evaluation of this non-drainage surgery, where in the attempt to go as much extraocular as possible, I went ahead with the study of a non-drainage procedure. If I have to make a decision with a large amount of SRF, I would probably either go for a drainage procedure in this, or I would straight away go for a repeat intraocular procedure.
Very true. Very true. And how was IOP was maintained after the surgery?
Yes, so the IOP was maintained.
You are putting the encerclage back.
Yeah, sir. As we all know, there was the IOP did not fluctuate till the first post-operative month, and the fluctuation was not present at third post-operative month also. It is very similar to the performance of a normal sterile buccal procedure, where there is not much fluctuation of IOP to dangerous levels of, say, of the glaucomatous range, which is dangerous to the eye. Mild fluctuations of 2 to 3 millimeters of mercury actually did not put the eye at risk of optic nerve damage. So that was fine.
No, these are all cases of having a silicone oil filled eye, isn't it?
Yes, yes, sir.
So that's why, like in a normal eye, when you have a vitreous filled eye, so there is a chance of vitreous shrinkage, but the volume of silicone oil will not shrink.
Yeah, so, sir. In those cases, while I was tightening the encircling band, the port that I used to insert the chandelier endoillumination was also used to express some amount of silicon oil that could have been escaped without hampering the oil meniscus level, both intraoperatively, and that observation was also observed post-operatively as well. Silicon oil being viscous, it takes it takes a considerable amount of pressure to express those when you compare that to fluid. So silicon oil expression out of just 1 or 2 blobs did not, without affecting the meniscus height, gave good tamponade and did not result in significant IOP rise post-surgery.
Fantastic. You have answered all the questions like an experienced surgeon. Thank you.
Thank you, sir.
One small question that I would have, Bibhuti,
yes,
is when you're removing the endoilluminator, it's true that the silicon oil is a viscous substance,
yes,
and it would come out. But it's a control on the silicon oil that could dribble out. How would you maintain it? How would you ensure?
So I didn't get the last part of your question. Can you please come again with that? The last part of the question.
What I said is, when you're taking out the endoilluminator, so see dribble of the silicon oil, how would you prevent it, and how would you gauge that dribble?
Sir, that dribble is of course it is visible, but it is very much preventable by the use of a normal plug. You just need to have an assistant who can provide you the plug at that very moment while you're taking out the endoilluminator. And once the endoilluminator is out, and as soon as it is out, you insert the plug. Just like we used to do in the systems which did not have a proper IOP control pre and post, or in the previous machines of Accurus, where we had to be very cautious, and with the larger gauges, when we had to be very cautious about fluctuations of IOP, while inserting the 20 gauges, sudden hypotony, sudden risk of caudal attachments, risk of intraocular bleed. So what we used to do was we used to plug it instantly. The same cautious approach, if we apply to this procedure, albeit of course with the presence of an experienced assistant, it's not much of a problem. I mean, in my case, that wasn't a problem.
True, but here it is coupled with your encerclage as well as your buccal, which is actually tightening it, right? So that is a little different from what you would have in a vitrectomized silicone-filled eye. Is it not? So at one end, you're tightening the buccal, and at the other end, you have to prevent seepage of the silicone. So I want to know about that balance. How would you strike that balance?
Sir, it is, sir, okay, so that I used to, I have omitted that in my surgical step, that I used to do with the use of a releasable 7-0 slip knot suture over the entry point of the trocar. So with the slip knot, it is a temporary suture. So once we have passed the encircling band, once we've done the final tie, we just temporarily release the slip knot and let the silicon oil seep. You will notice that in an already vitrectomized eye with the conjunctival peritomy done, it's not as self-sealing. The entry is not as self-sealing as it is with the virgin eye. So when the entry is not as self-sealing, it gives that window for the oil to just seep out in the right amount, and that can be actually titrated with the pull of the recti muscles with the cotton sutures. Those things can be, the oil can be expressed out in a limited fashion because of the slip knot and because of the not so self-sealing nature of the wound.
Okay. Now my second question is, you use a 276. That is what you said.
Yes.
Or in all cases?
Sir, in all my cases, although you could I actually shifted those 276 buckles as posterior as I can, but to use I thought of using a 279, but then that would have been flirting too much with an already operated eye. So that was where I stopped and excluded those eyes from this surgery, in which even a 276 buckles posterior shift could not cover the break at least on the anterior slope. Then at least on the posterior slope. So if till the time that was, if I could not achieve that with the 276, I stopped. I did not venture into a 279. So I have not used a broad buckle in any of my cases.
Okay. Right. Thank you, Bibhuti.
And also the broad buckle use would have actually caused increased seepage of the silicone oil required to maintain the intraocular pressure. Thereby, it may have hampered with the tamponade because most of my cases were inferior detachments. And as you know, in inferior detachment, we have to have an oil fill eye which has to have a position even with the sterile buckle at least for the first day when the retina gets attached. So if I flirt too much with the oil in time to place the 279 buckle, the expansion would be too much to actually obviate the use of oil as an indenter inside, as a tamponade inside the eye. So
how many of your cases did you drain of the SRS?
None. As I said, my the limitation of my surgery was a non-drainage because the maximum attempt was for me to keep it as extraocular as possible. So a drainage procedure was not done. If I felt, one of the patients failed because of the non-drainage surgery. That was the one unsuccessful case that I had.
Okay. Right.
Just a quick comment, Dr. Bibhuti.
Yes, sir.
What you can do is once you have the endo illuminator, you
Yes,
can have a guide. You can have a guide, and by which you can put a 30 gauge needle will be difficult, but you can put a 26 gauge needle into the subretinal space from the external part, and then just slowly withdraw that fluid. The thin fluid can be there, and that can take care of it. So improve the outcome.
Yes, absolutely. That is what the entire point was. That could have obviously been done, but the entire point was to keep it as extraocular as possible. That is why I performed a non-drainage surgery. Actually, along with performing a drainage surgery, what else could be done is to have a comparative evaluation where we keep the situations of both the groups similar in cases of detachments as to why the detachment happens, what is the cause and what is the effect, etc. And then compare the outcomes of vitrectomy versus EASB. And these two things, I think, can add on to this study to make it a more formidable one.
Right, then I think
again,
questions, and we can go to the next speaker.
We'll move it up. We'll have later the question session. We have a lot of other papers. Carry on.
Thank you so much, sir.
वो मेरा एक्चुअली ये हो गया था.
Hello.
Dr. Janti, yeah, please
yes, sir.
share your
Hello. Yeah. Shall I start, sir? Hello. Am I audible?
Yes, you are very much audible.
Okay. A very good evening to all of you present here. And before starting, I would just like to confess that it's a really very small, brief case review. And initially, I had planned that I will present it as a poster, but since the normal conferences are not being held this year, so I would like to specially thank Chairman Scientific Committee, Dr. Bharti Kashyap ma'am, for giving me this opportunity to present this. And at the outset, I would like to tell that when the first one of my patients presented with calotropis toxicity, like he had an exposure to latex of calotropis, honestly speaking, I had no idea how to proceed because during our PG days, I had never read about this. So I searched for the literature and then proceeded for the management. And so I just thought I will just briefly discuss. So to start with, calotropis procera is a member of the milkweed family, and it is a commonly seen shrub with worldwide distribution. In India, it is more commonly seen in Assam, Bihar, Jharkhand, West Bengal, in this part. And it is particularly seen in the wastelands, lands which are lying along the railway tracks, along waste areas. They are very commonly seen. And so this is the plant. These are perennial shrubs which grow to a height of 4 to 5 meter in length, and they produce these flowers, and it is commonly harvested for medicinal properties as well as more commonly for religious purposes. Like these flowers, these are pink and white in color, and these scenes are very common. All of us must have seen. And these flowers bloom in the month of February to June, and they are commonly used for making garland, and they are offered to Lord Shiva. So it is these are very common, and the thing is that any part of the tree, including the flowers, when cut or broken, it exudes a copious amount of milky latex, and this latex has set pro-inflammatory properties, and it is very irritant to the human tissues. And this latex, when caused to the eye, it can cause the inadvertent corneal blindness. So one should be very careful. And since this plant is very commonly seen, so it is not very uncommon to get cases from accidental exposure to this latex. And ocular injury from this plant is more commonly toxic due to exposure of latex, as I discussed, but it can be mechanical. So the purpose of the study is to discuss few cases of exposure to latex of calotropis, to discuss the various ocular effects of latex toxicity, and to improve awareness of calotropis keratitis amongst our fellow ophthalmologists. All cases of accidental exposure to calotropis were included in the study presenting between April to June 2020, and cases were followed up on alternate day in the first week, then at 10th day, and then at 1 month. So a brief review of these three cases will be done here. So the first two, out of the three cases, the two cases were male and one female. Although my sample size is very small to comment on the male to female ratio, but when I reviewed the literature, most of the studies have a male preponderance, but some also have a female preponderance since the females are more involved in the worshipping and preparing garlands. So the two cases presented within 12 hours of exposure, and then they were washed with Ringer's latex to remove any amount of any single drop of latex that was in the eye. And the second case, it presented after 48 hours, and he was already on some antibiotics and lubricants and some local doctor. So presenting complaints, so almost all patients complained of immediate burning and watering sensation, followed by redness and grittiness, and then they also complained of diminished vision simultaneously. So coming to demographics, the age were mostly in the age group of 25 to 40, and all patients had a variably reduced visual acuity on presentation. They all had reduced visual acuity, but on starting the prednisolone eye drop, the visual acuity started to improve from the second day itself, and by 10th day, all had reached the visual acuity of 6/6. Slit lamp findings include lid edema in one of the patients due to contact dermatitis. There was circumcorneal congestion and corneal edema with numerous descent membrane folds. Corneal epithelium was found to be intact in all my three patients, but in some studies, due to inadvertent rubbing, like when the latex gets exposed, it causes quite burning. So mild epithelial erosions have been reported in other studies. There was no significant AC reaction, and intraocular pressure was within normal range. So this is one of the patients with DM folds and the congestion. So, and the lady presented with lid edema with congestion and corneal edema, and this is one of the other pictures. So management, as I said earlier, the patients who presented initially, they were washed with Ringer's latex, and then they were started on topical prednisolone eye drops 4-hourly. Hypertonic saline eye drops was also started to reduce the edema, and then supportive lubricants. Follow-up was done after 2 days, and the stromal edema and the DM folds just started to reduce significantly, and by day 10, the inflammation had reduced. I had planned to do a specular microscopy at 1 month and 3 months, but unfortunately, the patients did not turn up to see the endothelial cell count. So as we all know, the latex, it is said to contain various poisonous and alkaloid substance, which is known to cause the inflammation. Shiv Kumar and Kimol injected dried latex in animal eyes and found that it causes intense inflammation. Mezen et al. Also said that the reduced endothelial cell count may be due to the direct toxicity of the latex when the latex penetrates the epithelium. The best Indian study has been done by Besok et al., and they did a retrospective analysis of 29 patients, and they had a variety of manifestations ranging from keratitis to keratouveitis to raised intraocular pressure, and they, on long-term follow-up, they also reported endothelial cell loss. So to take home message is that simple health education such as hand washing, protective eye gear, and rubbing of the eye should be very important, and they should be told to the patients. And ophthalmologists should also be aware of such acute effects of some of these local shrubs. Thank you.
Thank you, Dr. Jayanti.
Yes.
Over to the judges, please.
Nice presentation, Dr. Jayanti. So what would be your advice to the general population, and how would you transmit this advice to the general population about the calotropist toxicity?
Sir, first of all, I would ask them to use the protective eye goggles, because I cannot stop them from using, and because for many of them these are their bread and butter, like for selling these garlands. So I can use tell them to use protective eye gear, and if they are not using that, then I can tell them to not to rub their eyes, just to protect their eyes, and if at all it goes into the eyes, they have to immediately wash it and not to rub it.
Well, Dr. Jayanti, so
yes,
calotropist is known for its toxicity, right? You have
yes,
proved
sir.
it, others have also proved it. So
Yes, sir.
what my point was is, how will you actually make people understand that calotropist can have toxicity which can cause blindness as well, and also some amount of permanent damage as well? So what would be your line of propagation? Would it be through the media? Would it be through the government? Any thoughts on it?
Yes, sir. In region in which, especially during the month of March, like during the Shivratri, that time it's peak use of this plant particularly. So that time we can use pamphlets, and we can create an awareness, or we can, whenever the patients, low profile patients, we can create. Whenever we go to camps, sir, that time we can just mention a word about this.
There has to be something beyond what has already been published, like
yes, sir, yes, sir.
Published. So you have to go beyond that. So
yes,
that's the point that I was trying to make. So
yes,
how will
sir.
you go beyond so that this toxicity can be diminished? Right.
Sir, yeah. So we can take the help of social media, IC activities. Yeah.
You have answered it well.
Yes, sir.
That's what I'm saying. So the next part of your study should be, these are the steps that I took in the state of Jharkhand to decrease the toxicity of calotropist.
Yes, sir.
Right. Thank you.
Thank you, sir.
Yeah, the next speaker is Dr. Neha Shilpi. She'll be talking about amblyopia therapy. Dr. Neha Shilpi, unmute yourself and share your screen.
Yes, sir. Am I audible?
Yes, very much. Share your screen. That's visible.
Yes, sir. Okay.
Go to slideshow.
Yeah. Okay. So, good evening to all. I'll be presenting on role of amblyopia therapy in children with repair penetrating ocular trauma. And my guide is Dr. Sinha, sir. So, according to the eye trauma terminology system, ocular injuries are broadly divided into open globe and closed globe injuries. The open globe injuries are further divided into rupture and laceration, and penetrating injuries come under laceration, which is our field of interest for today.
Dr. Neha,
yes,
I think you have to do a slide share. Are you all getting her screen right, Bibhuti?
No, only a very small, I think it is.
So I think you have to go to screen share.
You have to go to slideshow, I think. She has already, she's
sitting in rehearsal mode, I think.
It has to be maximized somehow.
Slides we can see, but the size is very small. I think. Yeah, what is there? Just on the left side of the tips.
Which one, sir?
Just on the left side of the tips.
Left side of the tips.
There are three small icons. One is end show, the other is tips. And what is the third one?
No, Neha.
I can't get.
Neha, just listen to me. In the middle, there is an end show with a cross. No, you go and see in the middle. ऊपर cursor ऊपर ले जाओ बेटा. हाँ, बस अब उसके बगल में left में जाओ. Tips के बगल में. Tips के बगल में cursor लेकर के click on that.
Okay, what?
Which Which one, sir? This one.
Go little right.
Go a little more right.
Yes.
A little more right. A little more right. Right. Tips you are able to see, right? Tips. बीच में tips.
Query mark है. Query mark का left वाला.
Query mark.
एक तो है end show है. End show के
Exit
show के बगल.
I can see new share, pause share, annotate, remote control. End show I cannot see. And tips also I cannot see.
You can just right click your mouse and see what comes out.
Nothing. Okay, tips now I can see.
Yeah.
See.
Tips के बगल में देखो.
हाँ.
Tips के बगल ये वाला हाँ.
उसके yeah.
Tips.
हाँ वही.
Right. Yes.
Right.
But that is not active. I think that icon is not active.
That is not active.
Can she switch it off and start again all over again, so that probably there might be some way out?
She does not have any video, then she can present in this mode as well.
Yeah, correct.
I do have, but sir, if you all cannot see the slides clearly, then can I switch off the rehearsal mode and present in the slideshow mode?
Yes, yes. Yeah. Please go ahead.
Okay, so I'll start from the beginning. Good evening to all. My topic for today is role of amblyopia therapy in children with repaired penetrating ocular trauma, and it was guided by Dr. V.B. Sinha, sir. So, according to the Birmingham Eye Trauma Terminology Classification, ocular injuries are broadly classified into open globe and closed globe injuries. And open globe injuries are further classified into rupture and laceration. And the penetrating injuries comes under laceration, which is our field of interest for today. So the zones of injuries are classified. In zone 1, we include injuries of the cornea till the limbus. In zone 2, injuries beyond that till 5 mm into the sclera. And any injury posterior to the 5 mm zone in the sclera is considered in zone 3. So ocular trauma is a major preventable cause of uniocular vision loss in pediatric age group. The poor prognostic factors include poor visual acuity at presentation, rupture globe, zone 3 injuries, any associated retinal detachment or vitreous hemorrhage or dislocation of the lens. So with all this in mind, what our research question was that would amblyopia therapy help in pediatric ocular trauma patients? And with this in mind, we conducted this study with the purpose to assess the visual outcome in pediatric cases of repaired penetrating ocular trauma after amblyopia therapy. So this was a prospective comparative study. The study was conducted from November 2018 to March 2020. The place of study was RIU RIMS Ranchi, and ethical approval was duly taken from the Institutional Ethics Committee. We included children aged 5 to 10 years with penetrating injury in zone 1 repaired at our tertiary care center. We excluded patients with zone 2 or 3 injuries, those who had trauma to the lens or posterior segment structures. And patients whose parents were not willing for follow-up or those who were lost to follow-up were also excluded. Intraoperatively, after thorough wound exploration, repair of the penetrating injury was done using monofilament suture. In the post-operative period, the post-op medications were given like antibiotics, steroids and cycloplegics. They were continued for a period of 6 weeks. And apart from that, what we did extra was 6 hours daily occlusion was advised for 6 months. Suture removal was done at 6 weeks. Our outcome measure was visual acuity, which was assessed at 1 month, 3 months and 6 months post-operatively. Statistical analysis was done. First, the data was entered in Microsoft Excel 2010. Continuous data was expressed in the form of mean plus minus standard deviation, and paired t-test was done to compare visual acuity between different follow-ups. So coming to results, the total number of patients in our study were 44. The mean age of the patients was 8.23 plus minus 1.49 years. There was a clear-cut male preponderance with 36 males and 8 females. So the ratio was 4.5:1. The presenting visual acuity was hand movement close to face in 19 patients, that is 43.18%. 17 patients had visual acuity between finger counting at 1 meter to finger counting at 3 meters, that is 38.62%. 7 patients had vision between finger counting at 4 meters to finger counting at 6 meters, that is 15.91%. And 1 patient had presenting visual acuity of 6.36. Iris prolapse was seen in 31 patients. The post-operative mean visual acuity at 1 month, 3 months, and 6 months is being shown in this chart. So it was in logMAR, the visual acuity was, the mean visual acuity was 0.98 at 1 month, it was 0.84 at 3 months, and 0.63 at 6 months. And when pair t-test was done, so the difference was statistically significant with p-value of less than 0.401 between 1 month to 3 months, as well as between 3 months and 6 months. So the difference between different follow-ups was statistically significant. Now, I would like to say that after a thorough literature search, we could not find much literature on this. Not many studies. There is just one study in literature which is related to our topic. I'll come to that later on. There are multiple studies on the epidemiological profile and which support our finding also. Like there is this study from northern India, and there also they had seen a male-female ratio of 2.9:1. Then there is this another study conducted at AIIMS, which studied the pattern of pediatric ocular trauma. They also saw a male preponderance, and children of 5 years and older were mostly affected. Now coming to the amblyopia studies, the pediatric eye disease study group, the PEDIC group, they have published 17 amblyopia treatment studies. And the major results from those studies are that patching is an effective treatment of amblyopia. When they compared ideal number of hours, so whether the patching was done for 2 hours or 6 hours, the difference was not statistically significant. Same was seen for part-time occlusion for 6 hours versus full-time occlusion. In both the cases, the difference was not statistically significant. And one more important finding was that near work during patching led to more improvement. So this study, I was talking about, there is the study which is related to us. They studied amblyopia therapy in children with penetrating corneal injuries. The sample size of their study was less than ours. They had 26 patients. And they also found that amblyopia therapy was promising in those cases. So I would like to conclude that ours is an innovative and unique study because not much work has been done in this field. Amblyopia therapy improves visual outcome in children with repaired penetrating zone ocular trauma. This is especially important and clinically very relevant because if we can improve the visual outcome in cases of pediatric ocular trauma, then definitely ocular morbidity will reduce and their quality of life will improve very much. Further studies with larger sample size and longer duration of follow-up may provide more insight in this. Thank you for listening.
Thank you, Dr. Neha, for your presentation. Please unshare your screen.
Yes, sir.
Yeah, over to judges.
Yeah, Dr. Neha, am I audible?
Yes, yes.
Yes,
yeah,
sir.
Dr. Neha, this is a
Yes,
good presentation, good case series. But amblyopia therapy following any kind of intraocular surgery, that is one of the most important part of it. But do you have a classification of what kind of treatment is helpful more? Do you have a sub-analysis of those treatment protocol?
Sir, our treatment protocol was uniform for all the patients. Like we did a follow-up for 6 months, and till 6 months, all the patients were advised patching for 6 hours. And those who were non-compliant, those who did not follow up were not included in our study. So the 44 patients that I have, they have done 6 months patching for 6 hours daily.
Okay, so all of them are having a lens status. What is the lens status of all of them?
Lens was not involved in any of the cases. So lens was normal. Yes, sir. My exclusion criteria was involvement of the lens. Those cases I had not taken.
Okay, so what is your take-home message from this study? So anything corneal involvement? Yes, the rehabilitation will definitely take care of the visual improvement. So any specific new thing you wanted to tell us?
Yes, sir. Yes, sir. So what I want to tell is that after repair, refractive correction we all give routinely to all the patients. But then amblyopia therapy is something which is not advised to these patients who with repaired ocular trauma. Many cases have poor prognosis. Those who have involvement in zone 2 or 3 or involvement of the posterior segment structures, they don't have a better prognosis. So advising amblyopia therapy to them won't be helpful. But then these cases which I included, zone 1 cases, so they definitely have a potential to improve their vision. And after repair and after refractive correction, I think amblyopia therapy must be given to these patients, and that will definitely improve the visual outcome in these cases. So this is something which is not routinely done. We don't advise patching to these cases.
Correct. Thank you.
Good, Dr. Neha, and nice presentation. What was the length of your follow-up?
So 6 months. 6 months was the follow-up.
Okay. So again, you know, if it can be extended to a year and more,
yes, yes, sir.
Goes up.
Yes,
and
I'm trying to do that.
Right. And was it 6 hours for every patient, or was it 4 hours also?
No, sir. Here we advise 6 hours for every patient. We try to keep it uniform. That is why.
Okay, because literature also supports that 4 hours is also equally.
Yes,
fine. Okay, Dr. Neha. Good presentation. Thank you.
thank you, sir.
Okay. Now the next presenter is Dr. Payal Mukherjee. Dr. Payal Mukherjee, yeah, kindly share your screen and start your presentation.
Am I audible to all?
Yes, yes, you're audible and your slides are also visible. Go to.
Okay, good evening everybody. The topic of my presentation is role of ceticoline for management of myopic amblyopia patients in tertiary care hospital in India. I have got no financial interest for this study. Myopia is a very common condition affecting people of all age groups. Nowadays, the increasing trend is seen in people of young and middle age group. Ceticoline, that is cytidine 5-diphosphocholine, stimulates dopaminergic system in the brain and retina, thus increases retinal neurotransmitter dopamine levels. Chronic ceticoline treatment leads to increase in dopamine receptor densities and promotes partial recovery of dopamine receptor functions, which normally decrease with aging. It also activates biosynthesis of phosphatidylcholine in neuronal cell membranes, thus an increased neurotransmitter level and enhanced neuroprotection. It stimulates glutathione synthesis and facilitates preservation of sphingomyelin, thus promotes signal transduction in nerve cells of retina. It reduces RNFL damage by reducing the nitric oxide synthase levels and attenuates nitric oxide functions in the neurons of retina and spinal cord. In the current study, we aim to study the effects of oral ceticoline as a treatment option in myopic amblyopia by looking at the progression, arrest, or regression of myopia. In this is a observational hospital-based study. It was performed at the Tertiary Care Center of India between June 2018 to March 2019. Patients of myopic amblyopia of age group of 5 to 30 years were included in the study. All participants provided informed consent before being included in the study. Detailed eye examination, including visual acuity, diffraction, dilated fundoscopy by indirect ophthalmoscope were done, and the worst eye of the patient was taken for examination. My inclusion criteria included best corrective visual acuity of less than 660 and myopia of more than -6 diopter. Media opacity, squint, history of previous ocular surgery and ocular trauma patients were excluded from my study. The whole study population of 378 patients was randomly divided into two groups. Group A had 203 patients. They were given oral ceticoline, that is tab 500 mg daily OD for 12 weeks. And group B had 175 patients and were given placebo, that is any antioxidant, daily for 12 weeks. After 12 weeks of ceticoline treatment, the patients were called for follow-up after 1 month, 3 months and 6 months. Visual acuity and refraction were done in each follow-up visit. Visual acuity of the last follow-up visit, that is of the 6th month, was plotted and results were observed. Data was analyzed by SPSS software, and any difference associated with chance probability of less than 0.05 was considered statistically significant. This study included 378 patients of myopic amblyopia of age group 5 to 30 years divided into two groups. Group A contained 203 patients and Group B contained 175 patients. This is a graph showing age-wise distribution of the maximum activity was seen in the age group of 5 to 10 years, followed by the age group of 10 to 15 years. This is the table of data regarding sex prevalence of patients and effects of CT. About 64% of the statistical data was not shown to be significant. The graph shows the same. This study showed that there is some improvement in visual acuity and refractive status of eyes of patients with acetylcholine. The improvement was markedly noted in patients of age group of 5 to 15 years. The highest improvement is seen in the age group of 5 to 10 years, that is 68.42%. After the age of 15 years, refractive status became stable with the use of glasses. Among males and females, females showed a comparatively better result in improvement in refractive status and visual acuity with the use of acetylcholine. Currently, there is no study that is available regarding role of oral acetylcholine in progression, arrest or regression of myopic amblyopia in patients. This is the only lacuna. But there are studies which was published by Jensen Mayo et al. He showed that intraperitoneal injection of acetylcholine in guinea pigs retarded the myopic shift induced by form deprivation. Another study published by Prachi Pawar et al. Showed that improvement in visual acuity with acetylcholine along with patching. It was a combination study of acetylcholine and patching, which was significantly more than that which was done with patching alone in 1 year of treatment of amblyopia. Many studies have shown neuroprotective effects of acetylcholine in diseases like glaucoma, amblyopia, non-arthritic ischemic optic neuropathy, cerebral stroke, dementia, Parkinson's, and many other diseases. This is attributed to increased level of dopamine in the retinal neural cells, and it prevents the RNFL and other retinal neural cells from degradation. There were some limitations in my study, like the sample size was small, and due to high cost of the tablet, the compliance of patients were about 80%, and many patients didn't turn up for follow-up. We didn't calculate the axial length of the eyes prior to and after the treatment, and we didn't titrate the dose of acetylcholine with age and body weight of the patient. To conclude, acetylcholine has got some role in improvement of visual acuity and refractive status of eye of patients in high myopia, resulting in myopic amblyopia till 20 years of age and in females. It may prove to be a promising therapy in retardation of myopia progression and myopic amblyopia in future. Thank you.
That was a very nice presentation, Dr. Payal.
Thank
Just
you,
finished
sir.
in time. Judges, please. Dr. Partha Biswas, Dr. Rupak.
I don't have any questions. She has explained it very nicely. So,
okay. Dr. Partha, please. Dr. Bharti, shall we move on to the next speaker?
Yes, yes.
Thank you. Thank
Yes.
you, ma'am. Thank you,
So
everyone.
we, thank you, Dr. Payal. Thank you, Dr. Payal. Next speaker is Dr. Pinky Pal. She'll be talking about evaluation of patients' eye care in tertiary center during pandemic COVID-19 in Jharkhand as a warrior. Dr. Pinky, you can share your screen. Dr. Pinky, please unmute yourself. Please unmute yourself, Dr. Pinky. There is a small icon on the left bottom of your screen. Yeah, it's there.
Am I audible, sir?
You are audible.
Yeah.
Yes.
Good evening, everyone.
But, we can't see your screen. You have to share your screen. Share your presentation.
Share your screen.
Open the presentation on your desktop, and then you will see there is a Zoom window. There is a small green icon, share screen, at the bottom.
This is okay, sir?
Yeah, it has come. Go to the slideshow. Yes.
Okay, sir.
Yeah.
I would like to first of all thank to my Dr. Bharti madam who has given me opportunity. My topic is evaluation of patient care in tertiary center with pandemic COVID-19 in Jharkhand as a barrier. The coronavirus disease COVID-19 pandemic caused by the highly contagious virus named severe acute respiratory disease syndrome coronavirus 2 has caused mayhem across the world. On 24th March 2020, the government of India under the Prime Minister Surendra Modi ordered a national-wide lockdown for 21st day, but in Jharkhand state, this lockdown extended up to the 31st March with some relaxation. In this critical situation, the government's healthcare sector is expected to be forerunner, and the healthcare providers have the responsibility of not only providing adequate care to the patient, but also protecting themselves from the prey to this potentially deadly disease. This is very challenging to providing healthcare, especially in our department with limited safety and resources. In my government hospital and my own hospital has been providing all the care during this critical time when almost all private clinics and hospitals shut down their door to the patients. My motto to evaluate the effect of COVID-19 pandemic and Jharkhand lockdown on patient care at a tertiary care ophthalmology department and made ourselves as a corona barrier. This is the guideline which are issued by the NPCB guideline, and first of all you can see the all eye facility to carry out routine clinical activities including OPD, IPD and surgical procedure in all areas except the containment areas in red zone. And the last one I just focus, pre-surgical COVID test on the patient is not mandatory. This is the comparison of the number of OPD cases during the previous year and COVID-19. As you see, in the March and the September in the last year, 10,000 patient has come, but in the March and the September in the COVID time, the patient is little bit decreased. Little bit not the larger number is decreased. Now emergency cases of COVID period OPD 1120 cases were entertained with the CVS computer vision syndrome is very much on online studies and mainly in the children very much complaint of the computer vision syndrome than red eye and the conjunctivitis. This is the non-emergency cases where the 1050 cases were entertained and the most important headache and eye irritation and mostly mask user person. Now the retina cases in COVID, 30 cases were entertained with the hypertension most important and the diabetic mellitus and the vitreous CSCR, optic atrophy and CRVO. This is the OT cases in the previous year where the more than 100 cases were done and minor OT more than 90 cases in the previous year. But in this effect of the lockdown, the cases is very much decreased like 25 cases and minor OT is little bit 60 to 70. This is my telemedicine and awareness program. I thank to a media person where we can connect with the patient in the remote areas. This is my telemedicine eSanjeevani app and the WhatsApp messages and the phone calls that attend in the COVID time. This is a total 300 patients were advised during the COVID time by this media person and ad and the telephonic contact and WhatsApp messages. This is some protection taken in the OPD. This is some protection also taken in OPD, that is the 2-meter distance, and this is the X-ray plate slit in the slit lamp. This is a protection taken in the OT in the COVID era. This is the patient. I want to ask this patient, one patient hypermat cat, and we go through this patient for the due to the hypermat cat, we go to the eye surgery. Immediately my surgery started first week of July. This is the AC hyperemia, hyphema in the AC. This also COVID, without COVID, we tackle this patient. This is the iris prolapse. This is the foreign body, and this is the mat cat patients. This is the OPD cases. This is not the emergency, but not least the emergency. This is all the emergency, non-emergency cases in my OPD. This is also a corneal ulcer. About 15 cases were entered in the corneal ulcer and then do not go outside due to the lockdown. This is the trauma cases. This is the cystitis cases. I thank to my paramedical barriers in the COVID time in our department, Mr. Sankar Mahato, Mantosh Kumar, Anita Devi, Sanjay Vavri, which are all always supported me during this period. This is the COVID sampling in Southern Hospital. Now the results. Total number of OPD visited in the COVID time lockdown 2,300. By telemedicine and WhatsApp approx 300. On contrary, total number of OPD visited during the corresponding period last year approx 10,000. That means 166 patients visited per day in COVID time. 13 cases visited per day, about 82% patient reduced during this period. We covered all the areas, remote areas nearby Bokar, Lagiri, Chandrapura, Dhanbad, Purulia. All elective surgery were postponed during 21st March to 13th, and again it started first week of July until yet with emergency cases, MADCAT, HyperMed, LIG, and one-night patients. No eye camp, no glaucoma walk and week, no school screening. Eye donation paper filled by the 4 people in contrary to 30 people last year, and I see assault and trauma cases increased during the lockdown period. Now the discussion. The inability of the patient to reach the hospital for timely treatment has been another big problem during this health emergency, but our district hospital were providing all facilities as soon as could in spite of less manpower because our health workers engaged in the COVID duty and the camp. COVID test also very big problem, only depends on rapid antigen true. RT-PCR is major problem because it takes a lots of time and huge pressure on the medical colleges. Some patients have been providing emergency treatment without COVID test and humanity ground and take it like a barrier. Now come to the conclusion. A significant number of patients could not get adequate treatment in this lockdown due to the living in remote areas, not able to come in hospital, but thanks to our media person and telemedicine and WhatsApp contact, we could reach the people in spite of serving as good as possible. The battle with the COVID-19 is expected to continue for a long time, and we have to prepare ourselves to deal with such a health emergency by government and private too. The government also realized the manpower crisis as well as what should have real facility available in the primary and the tertiary centers. My tribute to the Corona martyrs, the Indian Medical Association has dedicated, released 515 Indian doctors who come their life in the COVID-19, and more than half is of government sector. Little bit contribute to the my Corona martyrs. This is a big salute to my lab technician who continuously do their job without their health issue and without any leave without any leave. They're continuously doing the COVID duty and over engaged in the COVID period time. No any financial interest. Thank you for your attention.
Thank you, Dr. Pinky, for your presentation. I request the judges if they have anything to ask for.
Not very specific question, but would like to congratulate for being as a warrior. Good compilation of data.
Thank you, sir.
But again, too much of just a suggestion. Just too much of data in one slide, then the slide becomes a little crowded. For presentation, I think if you can put the salient points and then discuss on that. So that will be the best way of
a little bit time to get prepared for all the slides. Sorry, sir.
I know. This is just a suggestion.
Partha.
Okay.
Dr. Pinky, very nice initiative that you have taken, and a comparative study with other studies which have done similar exercise, could have given a little more importance to the subject, and especially in your community, what you have done, that would have, been highlighted.
Okay, sir. Sir, this is a little bit time to prepare the slides. We are very overloaded, sir, because in Southern Hospital, dedicated hospital as a district hospital, and nearby all the government hospital, there is nothing, any government hospital nearby it, sir. And just we are doing our jobs, sir, in the COVID time. And I share one thing, sir, कि one eye patient came to me, मेरा आँख का ऑपरेशन कर दीजिए बेटी, मैंने मुझे देखना नहीं आता, मेरा एक आँख ही नहीं है. So that patient encouraged me to do the OT, and I started my OT in the first week of July, sir. and with a proper guideline. And I share one thing, sir. This patient is not COVID tested because this patient is very emergent patient, and in lots of use on the COVID test, sir, RT-PCR, and RT-PCR, this is beyond limit, sir, because it takes 10, 12, 15 days, and patient is waiting for the results. I'm COVID positive or COVID negative. But my staff, my colleague are giving me an opportunity to do it, sir. And with the limited resources and limited safety guards, sir, we are doing very much work in the COVID times, sir. We are
Wonderful. You are a COVID warrior, Dr. Pinky. Congratulations.
Thank
Very
you,
good.
sir. Thank you, sir.
She's a known very hard worker.
Yes, yes. We all know that.
For the next presentation, I would like to call Dr. Seema. Dr. Seema Singh, you can unmute yourself
Yes,
and
sir.
share your slide.
Sir, am I audible?
Yes, yes, you are very much audible. Share your slide, please.
Yes, sir. So just a minute. So is this visible?
No, we can't see the slide.
You can see this slide. So I started to share.
There is a share screen icon. at
Yes,
the
sir,
bottom
I have done that.
Have you opened your presentation?
Yes, sir. So still it is not visible?
No, we can't see the presentation.
Sir,
First of all, open your presentation, then decrease it, and then share it, and then push that button will come.
Open your presentation and minimize it.
yes, sir, I have done that.
Then go to the Zoom window and click on the share screen.
Sir, is it visible now?
No,
no. Still we can't see it. Don't panic, just, yeah, now it's coming.
Okay, so the screen.
Yeah. Go to slideshow.
Slideshow. Sir, is it visible now?
Yes, yes. You
Okay.
can start your presentation.
Okay, thank you for the opportunity. I'm going to talk about BKC, which is a very common condition presenting in our OPD, and it contributes 5.1% of ocular allergy in India. Disease usually has a self-limiting course, but in perennial cases, it may lead to visual disabling complications such as keratoconus or limbal stem cell deficiency. The children may also suffer from disease-related limitations in day-to-day activities. We treat BKC usually by antihistamines, mast cell stabilizers, topical steroids. Topical steroid being the mainstay of treatment, but these all have limitations, like long-term use of steroids may cause cataract or glaucoma. That's where we need a therapy that is safe as well as effective in the long term. Through this study, we aim to evaluate the efficacy and safety of topical 0.03% tacrolimus eye ointment in patients with refractory BKC. This was a hospital-based study conducted over a period of 1 year, including 39 patients with refractory BKC. At the baseline, the symptoms were graded in a 0 to 3-4 grade scale, and the symptoms that were graded were itching during discharge, foreign body sensation, and redness. And the signs that were graded were conjunctival hyperemia, tarsal papillae, Horner-Tranter's dots, keratopathy or corneal neovascularization. We included patients of BKC which had undergone previous treatment with anti-allergic or topical steroid for a minimum of 3 weeks but still persisted with symptoms in the age group of 5 to 30 years. We excluded patients with pre-existing ocular infections or patients with shield ulcers, BKC with shield ulcers. We also excluded patients which were known to have a hypersensitivity to tacrolimus or cyclosporin. Limitation: this study did not include a control group because it was unethical to leave a patient untreated for such a long time. Now, the patients that were included were instructed to apply 0.03% tacrolimus eye ointment to conjunctival fornix BD for 3 months, along with a preservative-free carboxymethyl cellulose eye drop, 0.5% BD for 3 months. And then review was done at 1 week, 1 month, 3 months, 6 months, and so on. In all the follow-up visits, the symptoms and signs were graded, fluorescence staining was done, and intraocular pressure was noted. Patient was specifically asked about any possible side effects or adverse effects that they experienced. Now, the reduction in total signs and symptom scores from the baseline presentation was used as a determinant of efficacy. For statistical analysis, we use independent density test and ANOVA to differentiate the total symptom and sign score at baseline and then at each follow-up. Mean age was 13.63 years. We can see from this graph the majority of the portion belong to 6 to 10 or 11 to 15 year age group. Majority of the patients were males and the age onset of the disease was 5.16 years. Mean duration of illness was 8.47 years. And both in all the 30 patients, there were both eye involved. Type of VKC, the mixed form was the most prevalent type of VKC. Among the symptoms, itching was the most predominant symptom, followed by foreign body sensation, then came redness, then tearing, and then discharge. If we compare the mean symptom score of each symptom at regular follow-up period, when we compare this data using ANOVA, the p-value came out to be significant in all of the symptoms. Similarly, when we use the student peer t-test to compare between two follow-up periods, like in first column, day 1 versus week 1 was compared and the value was not significant, whereas the value for week 1 versus month 1 and month 1 versus month 3 was highly significant, which suggested that the tacrolimus started acting maximally at the period of second follow-up and third follow-up. The value for month 3 versus month 6 was not found to be significant. For signs, conjunctival hyperemia was the most predominant sign, followed by tarsal papillae, then hornet Tranter's dot, superficial punctate keratitis. In this study, there were no corneal vascularization patients. For mean scores, when we compared this using ANOVA, as a whole, that values came out to be statistically significant. In day 1 to week 1 comparison, the p-value was found to be significant only for superficial punctate keratitis, and the rest all of the signs, they improved in first, second, and third follow-up, and the p-value was found to be highly significant. When we compare the mean total score of cumulative symptom and sign scores out of at day 1 presentation, were found to be 19.34, and at 6 months of presentation, the total cumulative score for symptom and sign was found to be only 1, which meant that there was a reduction. For symptom individually, the symptom improved from 9.36 to 0.51, which was around 59%, and the signs improved from 9.98 to 0.49, which was around 63.2%. But at last follow-up, the sign scores started increasing, which suggested that there was kind of a recurrence problem. This is a graph showing a general decrease in trend at each of the follow-up, and at the last follow-up after 6 months, the signs kept on reappearing. This is one of the cases that had been treated at presentation, then after 6 months it improved really well using tacrolimus 0.03% ointment. As far as IOP was concerned, it shows a general increase in trend over the period of follow-up, but the p-value was not found to be statistically significant. Side effects, the only major side effect was mild ocular irritation in 6.67% cases. The treatment failure in 2% did not respond to treatment and were given topical steroids. 5 eyes out of 60 eyes showed recurrence, and these eyes showed recurrence after the 6-month follow-up. In discussion, most of the studies have used 0.1% tacrolimus ointment, but Chatterjee and Agarwal quoted that 0.03% tacrolimus is safe and can be used. Similarly, a study by Dr. Sunil Kumar and RIMS has also conducted a study, and they said that the study was significant. Safety profile, we need to conduct a blood level analysis. which was concluded by Ebi and Hara et al. Another study, which was a long-term study and conducted for 48
Time
months.
is up, Dr. Seema.
Yes, sir. For 48 months of follow-up was also found to be significant. So conclusion-wise, this can act as a potential role as a steroid-sparing agent. These are my references. Thank you.
Yeah, over to the judge.
Yeah, very good presentation,
Please
Dr.
unshare your screen, Dr. Seema.
Yes, sir. So just a minute, I'm not able to.
Okay,
So just a minute.
We can continue with the discussion.
Okay,
the judges might. Yeah.
Okay, good presentation, Dr. Seema, and a good analysis.
Thank you, sir.
Done.
Thank you, sir.
So, with the concentration that you have used,
Yes,
the irritation that you had said was mild.
Yes, sir.
Okay.
Yes, sir.
Whereas in the concentration of about 1%, the irritations are much higher. Is it
Yes,
not?
sir. Yes, sir. The previous, yes, sir. Yes, sir. The previous studies that have used 0.1% said that some of the patient even had to discontinue the medication because of 0.1% concentration. But in our study, only few patients said that there was a mild ocular irritation, but they did not have to discontinue it.
So that is a very significant aspect that you have found in your study.
Yes, sir.
So that's really good. And your follow-up period was how long?
Sir, it was 8 months. Mean period, follow-up period was 8 months. We could not follow that because after that the COVID period started and the patients did not came to the OPD. So that was limited only up to the period of 8 months.
Okay, fine, good. Again, when you are comparing,
Yes, sir.
so again, a contralateral study effect also gives a good strength to any of the studies that you are doing. Of course,
Yes,
with the committee approval as well as your patients of consent.
Yes, sir.
Yeah, very well planned and well executed study.
Thank
Analysis
you,
is also fantastic.
Thank you, sir.
Shall we move on to the next presentation? Dr. Suchitra Kumari.
Yes, sir.
Yeah, unmute yourself and share your screen. We will be presenting about pupillary abnormalities in type 2 diabetes mellitus as an indicator of diabetic autoimmune neuropathy, autonomic neuropathy.
Yes, sir.
Yeah, we can see the slides.
Okay, sir. I'll be starting in a minute, sir.
Yes, yes. Please go ahead.
So good evening, everyone. I'm going to present my study on pupillary abnormalities in type 2 diabetes mellitus as an indicator of diabetic autonomic neuropathy. So I have been guided by Dr. Professor Sinha and Dr. Neha Shilpi ma'am. So as we know, diabetic autonomic neuropathy is a recognized complication of type 2 diabetes mellitus. It is associated with the longer duration of disease. It affects the cardiovascular, gastrointestinal, genitourinary, pseudomotor, and ocular systems and thus leads to considerable morbidity and mortality. The identification of these high-risk subjects is therefore crucial to improve the long-term outcomes of people suffering with diabetes. The ocular autonomic nervous dysfunction includes small pupil size and impaired pupillary response to darkness or light. So what we use as the conventional diagnostic modality to diagnose the diabetic autonomic neuropathies include battery of tests, sophisticated and specific equipments, trained technicians, and are time-consuming, therefore limiting its common use in clinical practice. Whereas measuring horizontal pupil diameter and pupil cycle time is simple, non-invasive, and inexpensive. And also it has been studied in various disease conditions affecting the autonomic nervous system. So the aim of this study was to study the relation between pupil abnormalities and the underlying diabetic autonomic neuropathy. So it was a prospective observational cross-sectional study conducted between November 2018 to October 2020, and the cases were selected by systemic random sampling. We had included those type 2 diabetes mellitus patients who attended the ophthalmology or medicine OPD, those having irregular or non-symmetrical ripple, iris abnormalities, optic nerve diseases, or on medications which could affect the autonomic nervous system, or having any prior intraocular surgery or any systemic conditions like Parkinson's disease which could affect autonomic nervous system were excluded from the study. So informed consent was taken, and the patients were further divided into 2 groups based on their long-term diabetic complications. So to measure horizontal pupil diameter, we used a pupil ruler, and we measured the horizontal pupil diameter in dark light, and then in light also we measure the pupil diameter before and after dilatation with 1% tropicamide, and 16 minutes after using tropical, the horizontal pupil diameter was measured. So to measure pupil cycle time, we used a slit lamp and a stop clock. To measure the pupil cycle time, a very thin slit of light was made, like around 0.5 millimeter of thickness, and it was made to fall on the periphery of the pupil. As soon as it falls there, and retina gets the stimulus, and the constriction occurs. As soon as the constriction occurs, the stimulus is lost, and again dilatation occurs, and 100 such constriction and dilatation. 100 such constriction and dilatation constitutes of 1 pupil cycle time. So statistical analysis, for that we used a statistical package for social sciences, that SPSS version 21.0, and all the data were expressed as mean with the standard deviation. The statistical significance was assumed at p-values of less than 0.05. So in the results, a total of 62 type 2 diabetes mellitus patients and their 20 age and sex matched controls were taken, out of which 44 were females and 38 were males. The mean dark adapted horizontal pupil diameter was significantly smaller in diabetic groups than the control. The light adapted horizontal pupil diameter as well as horizontal pupil diameters taken 60 minutes after dilatation with 1% tropicamide was smaller than the control group. The difference was even more clinically significant in the group with complications. So here's a diagram where we can clearly see that the diabetic group had a clinically significant less horizontal pupil diameter in all the cases, in the dark and in the light before and after dilatation with tropicamide 1%. And both the absolute and relative changes in pupil size from darkness to light was less in the diabetic group. The pupil cycle time was significantly prolonged in the diabetic group as compared to the controls, and more evident in the group with complications. So here's another bar diagram. We can see that the pupil cycle time in the diabetic group has increased significantly as compared to the control group. So in discussion, the study provides novel evidence of early autonomic nervous system dysfunction in the natural history of diabetes, which progresses with duration of diabetes. The measurement of horizontal pupil diameter in dark as well as in light, along with pupil cycle time, is a valuable tool for the early detection of ANS dysfunction, and its utility in diabetic autonomic neuropathy screening has been observed in this study. This simple and inexpensive technique can potentially improve the outcome of patients with diabetic autonomic neuropathy by detecting it at a subclinical stage. Smith suggested that ocular autonomic nervous system dysfunction occurs before cardiovascular autonomic dysfunction, and the result of this study favors the same. Smith and Davis concluded that the resting pupil diameter in the dark adapted state is mainly under the sympathetic nervous system, and that smaller pupil in subjects with diabetes is a sign of sympathetic dysfunction. We found the mean horizontal pupil diameter was smaller in patients with diabetes as compared to the non-diabetic groups. So thus agreeing with the studies. And in our study with pupil cycle time was found longer in diabetic cases. At the same time, the rate of inability of measuring pupil cycle time was found more in the diabetic group. The 1% tropicamide works by paralyzing the parasympathetic constrictor drive, allowing the sympathetic input to the dilator to dominate. The loss of sympathetic tone in patients with diabetic neuropathy thus explains its less efficacy. Although autonomic nervous system dysfunction is crucial for abnormal pupillary light reactions, an additional contributory mechanism also results from structural changes of the iris in diabetes. So whatever we see in pupil changes, it's not completely due to the autonomic nervous system involvement and the use of manual methods of measurement of horizontal pupil diameter and pupil cycle time. The less number of controls along with inherent bias associated with hospital-based studies is a limitation of our study. To conclude, our results clearly show that sympathetic denervation does exist in the pupil of diabetic patients and that it can be assessed by using horizontal pupil diameter and pupil cycle time. The significant smaller horizontal pupil diameter and prolonged pupil cycle time in patients without diabetic autonomic neuropathy compared with that of healthy subjects could be a sign for early involvement of the pupil function before manifestation of systemic autonomic diabetic neuropathy. Following a few references, thank you very much.
Thank you, Dr. Suchitra, for a wonderful presentation. Now over to the judges, please.
Yeah, fantastic presentation, Dr. Suchitra. Very good observation, good originality. Would like to ask you, did you also cases?
Pardon, sir?
And Dr. Rupak, can you please repeat your question?
So I still can't hear it, sir.
Dr. Rupak, your voice is cracking. We are not able to.
Again, sorry. Is it better?
Yes.
I can hear it now.
Yeah. Did you check RAPD as well?
What's up?
RAPD. He was asking
So
about
RAPD. So those
RAPD.
excluded for my study, sir. So those were not included in my study. I had excluded those patients with RAPD, sir.
No, like why?
So if RAPD is there, optic nerve involvement must be there. So anyone having optic nerve involvement, we didn't include them. Our main focus was to concern with the autonomic nervous system, sir. So optic nerve involvement. So that's why I didn't include.
Fantastic. So you are dealing with the efferent pathway, not afferent pathway. So that's why RAPD has been excluded. What about the fundus picture? Is there any correlation with the fundus picture as well?
So the thing was retinopathy. I have included, sir. So retinopathy is one of the complications of the diabetic autonomic neuropathy. So among the diabetic group, the patients were further divided into two groups. So those who were having retinopathy were under the group who had diabetic autonomic neuropathy, sir. So only 9 patients among my 62 patients had diabetic autonomic neuropathy complications. So few of them had retinopathy for sure, sir. Hello.
Okay. So yeah.
Yes, sir.
Okay. So another one is that picking up of diabetic neuropathy. Sometimes you do the peripheral nerve test, electroneurogram or electromyogram. So do you have any correlation? Do you have any correlation with that? Like those are preclinical stage you can pick up.
Yes, actually, those things are there, sir, but those equipments are very costly. So we couldn't do these things. I have consulted my medicine co-PDs for those things, sir. So for my the reason of patients into diabetic, the patients into diabetic autonomic neuropathy, with diabetic autonomic neuropathy, I had those were diagnosed by the medicine patients. I didn't do these things, sir. The medicine PDs had done those, and I got the information from them, sir. So, but these are quite costly tests. So they had just done the vibratory sensations on the periphery.
Correct. Probably you can extend it to your study so that you know the correlation, you can have a much more good result out of that.
Thanks. I'll try, sir. Thank you, sir.
Carry on.
Thank you.
Thank
you, sir. Thank you.
Dr. Partha, you want to ask something? Thank you, Dr. Suchitra. So next I call upon Dr. Suman. Dr. Suman. Hello. Dr. Suman. Dr. Suman, are you there? Hello.
Hello.
Dr. Suman.
We're calling
you. We can hear, but Dr. Suman. Dr. Suman, are you sitting on the Dr. Seema's window? Hello. I think Dr. Suman is there.
She's
and
possibly on Dr. Seema's window.
She's using Dr. Seema's window, but I'm afraid she can't hear us probably. Hello, Dr. Suman, can you hear us?
Hello, am I audible?
Dr. Suman, yeah, you are audible, but are you able to hear what we are speaking?
Hello.
Can someone call her and...
Madam, can you hear us, Dr. Suman?
Yes, yes. Good evening, everyone. Yes, sir,
Yeah,
I can hear you.
Ma'am, yeah, little below your laptop and now go ahead, ma'am. थोड़ा सा नीचे कीजिए मैडम अपना लैपटॉप. हाँ,
Your
आप present कीजिए
presentation
मैम.
is
Okay.
visible.
Is it okay?
Your
Yes.
presentation is visible. You can start your presentation.
Okay. Good evening, everyone. My presentation is on ocular manifestations of atopic dermatitis and observational study in tertiary care center. Atopic dermatitis is a pruritic, chronic, relapsing inflammatory disease of skin. It affects genetically predisposed individuals and may express itself either as an infantile, childhood, or adult eczema. The disease activity is characterized by remission and recurrences. Long-standing atopic dermatitis with repeated scratching and rubbing of face predisposes the patient to various ocular manifestations. In recent years, there is an increasing recognition that atopic dermatitis can present with extracutaneous findings. Potential ocular complications include dermatitis of eyelid, blepharitis, keratoconjunctivitis, keratoconus, uveitis, anterior and posterior subcapsular cataract, retinal detachments, ocular herpes simplex virus infection. The severity and the extent of atopic dermatitis can be evaluated using a SCORAD index, which is divided as mild, moderate, severe with a score of mild less than 20, moderate with a score of 20.1 to 40, and a severe with a score less than 40. The aim of the study was designed to observe various ocular manifestations in atopic dermatitis patients in our hospital. Materials and methods. This observational study involved a total of 70 patients, in which included 41 males and 29 females. Detailed history of the patients, including symptoms, total disease duration, personal or family history of other atopic diseases, treatment history about the use of topical steroids, antihistamines, emollients, etc. were noted. The lid, the conjunctiva and cornea were examined. All patients had complete dilated fundus examination with indirect ophthalmoscope. Any evidence of cataract formation and retinal disorders was recorded. Of the 70 patients, 41 male and 29 females, the mean age of the patient was 13 years and the duration of the study was, duration of the atopic dermatitis was 6 months. Ocular involvement included 25 patients, of which 25 patients had dermatitis of eyelids, 21 patients had blepharoconjunctivitis, and 23 patients had atopic keratoconjunctivitis. One patient had posterior subcapsular cataract due to use of steroid. No fundus abnormalities were found in any cases in our observational study. Discussion. Atopic dermatitis is an itchy, fluctuating inflammatory disease. Repeated rubbing and scratching of the face can lead to certain ocular manifestations like periorbital darkening, Hurt-Hoag sign, and Denny-Morgan fold. We found ocular involvement to be more common in males. Karmi et al. Showed that personal and family history of atopic manifestations and atopic dermatitis has statistically significant results in patients with ocular problems, and this point is similar to the results in the study. In earlier studies, eyelid changes have been reported to occur in 16 to 62% of atopic dermatitis patients. Keratoconus in atopic dermatitis patients have been observed in 5.39%, but none of our patients had keratoconus. Conclusion. Ocular morbidities are very common in patients with atopic dermatitis. Regular follow-up with an ophthalmologist is required. Early diagnosis and intervention can alleviate the ocular morbidities in patients with atopic dermatitis. These were the references. Thank you very much.
Thank you, Dr. Suman, for finishing well within time. I request judges if they have anything to ask.
Dr. Suman, about the ocular manifestations that you have shown,
Yes, sir.
graphical tabulation
Yes, sir.
would have given better analysis of the ocular manifestation. That is number one. Number two is just going on to the ocular manifestation, and did you also go on to the treatment protocols that were observed?
Sir, these patients were already diagnosed as cases of atopic dermatitis from the pediatric and medicine department and have been referred to us.
For
Sorry,
the eye
sir?
problem?
Yes,
For the
sir.
eye?
Yes, sir. They have been referred to us and we have managed them.
Yeah, that management aspect also, and
Yes,
the
sir.
follow-up patients on the management,
Yes, sir.
we would have given more importance to the study, no?
Agreed, sir. Agreed.
Right.
Dr. Rupak, anything you would like to ask?
No, that's fine.
Shall we move on to the next, that will be the last presentation of this session. Dr. Taruni Kumari. Dr. Taruni. Dr. Taruni, yeah.
Yes, sir.
You unmute yourself and share your screen. Start the presentation. She'll be presenting a comparative study of a recurrence rate of pterygium excision with Bayer sclera technique and conjunctival autograph in RIMS, Ranchi. Please share your screen. Yeah.
Good evening, everyone. Today I am going to present on the experience of part of pterygium excision with
Can you be a little bit louder, Dr. Taruni?
Hello?
Yeah, can you be a little bit louder?
Yes, sir.
Yeah.
Today I am going to present on comparative study of recurrence of pterygium excision with Bayer sclera technique and conjunctival autograph in RIMS, Ranchi. The study revealed the comparison of recurrence rate between the conjunctival autograft with Bayer sclera technique in pterygium excision. Pterygium is a triangular fibrovascular subepithelial in growth of degenerative pulvar conjunctival tissue over the limbus onto the cornea. It is most common on the nasal side rather than temporal side. Ultraviolet exposure to irritant like the sand and wind and dryness and irritation are most common factor for development of pterygium. Most lesions are asymptomatic. Burning sensation, redness, irritation, and grittiness and foreign body sensation are other most common symptoms of pterygium. Pterygium interfere with the vision by obscuring the visual axis or induce astigmatism. Now, sign of pterygium is a triangular fold of conjunctiva encroaching on the cornea. These diagrams show the head of pterygium on cornea, neck in the limbal area, body extended between the limbus and canthus, and cap is the semilunar whitish infiltration. Now, grading of pterygium, grade 1, pterygium extended midway between the limbus and pupillary border, grade 2 extended up to the pupillary border, and grade 3 crosses the pupil. Treatment is divided into three parts: observation, medical management, and surgical management. Observation is mainly for the asymptomatic grade 1 patient, medical management for the symptomatic grade 2 and grade 3 pterygium. Commonly, eye drop used in treatment of pterygium is tear substitute and decongestant. Surgical management for mainly simple grade 2 and grade 3 pterygium, and mostly cosmetic purpose. Now, medical method. This is prospective randomized comparative clinical study. Patient with grade 2 or grade 3 pterygium presenting to Department of Ophthalmology in RIMS, Ranchi from October 2019 to May 2020 were included, selected for study. Patient randomly divided into two groups. Group A underwent into Bayer sclera technique, and Group B patient underwent conjunctival autograph. Group A in Group A patient, pterygium head was separated gently, including the adjacent tenant vessel with the help of number 11 blade or keratome. Abnormal tissue was cleaned from cornea with crescent and cauterized the Bayer sclera to achieve the hemostasis and left it as such. In Group B patient, after excision of pterygium, Bayer sclera is measured with the help of caliper, and autograph was taken from the superotemporal region of the bulbar conjunctiva of the same eye and sutured with the surrounding conjunctiva. Now, patching and bandaging done after instillation of antibiotic eye drop and eye ointment. Patient was followed up to regular interval of the week 1, 1 month, 3 months, and 6 months. This diagram shows the pterygium on the medial limb. First diagram shows the Beer sclera technique. In this diagram, pterygium is excised and Beer sclera is leave as such. In second diagram, show the graft is taken from the superior temporal part of bulbar conjunctiva and grafted over the Beer sclera. Total number of the 50% were selected in our study. Out of the 50 cases, 30 were female and 20 cases were male. 20% were operated for the Beer sclera technique and 30% were with the conjunctival autograft. In group A, recurrence rate was 40% and 33.3% recurrence in group B. This diagram shows the recurrence rate in different groups. In group A, 8% recur after the 6 months, and in group B, 4% recur after the 6 months. Now, discussion of this study. It is the most common disease in India because India lies within the periquater belt of the periquater pterygium belt. It is common in a patient below, uncommon in patient below the 20 year, patient older than the 40 year. And the patient is between the 20 to 40 years are reported to have the high incidence of pterygium. The main indication of pterygium excision are the chronic ocular irritation, decreased vision secondary to astigmatism. Number of surgery has been described as a method of pterygium. Pterygium treatment included Beer sclera resection followed by the mitomycin C application and pterygium excision plus conjunctival autograft placement, amniotic membrane graft, sliding and rotational flap. The difference between the Beer sclera technique and conjunctival autograft is that the free conjunctival graft usually taken from the superior bulbar conjunctiva is put over the Beer sclera following the pterygium excision. Take home message is, with this study we concluded that the conjunctival autograft was better and safe technique in prevention of recurrence rate as compared to Beer sclera technique. Thank you.
So yeah, with that, we come to the end of this session. That was really a very nice presentation, Roni. It was really encouraging that we had 14 presentations in this competitive session, and we must congratulate all the presenters who did a fantastic job and presented very good papers. Really, it's very enlightening, very heartening to see so many young ophthalmologists come and present with such finesse and such nice papers. So I would request Dr. Bharti Kashyap to please take over, and she has some surprises.
So we have just prepared a small virtual award ceremony. So we are going to play it. So,
it will take a couple of minutes time, I believe, for the judges to
compile the results and
send
send it to Google
the agency.
Yeah. But I would like them to see the award ceremony because it is for them only. So Dr. Partha, should we switch on play the award ceremony? Or
Yes. After such a hard work.
It's fun.
That will give them a break.
तो उसको चला दें?
Yes.
Before that, Bharti, I think I would really take 2 minutes of the time of these youngsters, and I'm sure it's very late, quite late in the evening, but still, I think the 14 presentations that we have gone through have really been eye-openers, and to the amount of work that is being done in Jharkhand. And it is very inspirational to see that the youngsters are doing good work, but I would like to congratulate their supervisors, their mentors, who have really taken these youngsters forward. Again, having said this, the presentations were of good quality, very good quality, and some presentations were exceptional, definitely. So it is for Jharkhand to see that every presentation goes to that national level. That's very important for us. So year by year, we need to step up the presentation quality, the presentation content, and go to the next level. So each of the presenters, I have one or two small tips to give. If it's not too late for them, and if it's not too late for you, Bharti, I think
No, it's not late for me, but then they should respond.
For your words, it's never late, sir. Please.
Yeah, you are so patient. All the judges are so patient. You are listening and answering and questioning. You give so much of time, but then all the presenters, I switch on the video.
Your words will be golden words for them, sir. Your words will be golden words for the young officers.
They are listening. Let him complete. Let him complete. Yeah, please, sir.
So, so what I would like to tell our youngsters is there were a few presentations. You would have watched all your colleagues' presentation, and you immediately would know that this presentation is of that quality. So if you think that your presentation can be improved, so next time you're presenting, it must improve. So that's about the presentation. The presentation is just one part of the evaluation. But the most important part is the content that you're going to present. Your content must be something that is beyond what others have said, others have proved, others have elucidated. Even if it is pterygium, which is a very, very common subject, something that has been dealt with over years and years and years, what you can present is pterygium in Jharkhand. Is there something new you can present on this? So the newness of your presentation is the most important thing. There was one presentation which started with my research question. So that is a very, very good point, or that is a very good slide to put in your presentation. My research question, yes, and at the end of your 20 slides or 15 slides, you have to answer that research question. From my study, this is what I answer. So, you know, right from the beginning to the end is a continuity that you have drawn. That's point number 2. Number 3 is when any presentation is being judged, as Dr. Bharti and our office bearers, Dr. Bibhuti, also said, that we are going to judge on the originality, on the content, on the analysis, on your presentation, and on your adherence to your time. So all these become important when you're presenting. Something else also becomes important. The format of your presentations. See, there were some slides, which were so full of sentences. When you're presenting, your presentation slides should just be a cue to your presentation. You don't have to, write down everything and you have to read from top to down and 10 lines in a slide. One slide should not contain more than 4 or 5 lines, and you have to complete your sentence. Okay. So your presentation should have just cues, should have just points there. The other thing is, it's a webinar. So please remember, even in webinar, you have to be aptly dressed and you have to have the light proper. You have to have a strong internet connection, very good, so that your presentation is flawless. Otherwise, how can you present this year and year of hard work that you have done? So this is culmination of your presentation. So, all these small things matter. And the last and the most important is rehearsing. Rehearsing in front of your colleagues, rehearsing in front of your teachers, and getting them to ask something that could put a hole in your presentation. So you are well prepared, and you have to, please remember that your judges don't know at all as much as you know. You know better about the subject you're presenting. So you have to answer with confidence. We might just know a few things, and but you have read much more of literature than we have. So, and it's also important that, you stick to your points, you stick to the aims and objectives of your study, and you give it a logical conclusion. So I think that's a lot of gyan from us. But if Rupak wishes to add something more, Rupak, please.
No, Partha. I think I also get a lot of
Dr. Rupak, we can't hear you.
Yeah, but
Yeah.
Is it
Rupak,
better?
your voice is breaking.
Yeah.
Yeah.
Still?
Yes, it's better.
Yeah, always whenever you listen Partha, you get some kind of extra information you get. So I'm also really honored to be part of this and I get information. The only thing is that your like the way Partha has explained everything, but you argue with your knowledge, but there should not be the body language should not be in a it should be in a humble way. So needless to say that.
Absolutely. So any of the presenters have anything to say? We have submitted the marks. So any presenters have anything to say about the judges? You know, it should be a two-way traffic. We are living in the 20th century and
yes.
Yes, we are going to show you. We have received, we have sent it, and we have received the result from the SAI, and we have sent it to the president. He will soon announce it. In the meantime, we are going to show you the award, the virtual award ceremony.
Please share the screen.
Please share.
So, Doctor.
क्या देख रहे हैं? आप क्या देख रहे
चलो ऑन करो. You all see it?
Yeah.
Did you like it?
Yeah, very good.
Very much. Thank you very much.
Sir, Doctor, you see the award ceremony?
Yeah, it was wonderful, wonderful.
Awesome.
Thank you.
I never looked that good.
And probably you'll be receiving the original certificate and the memento.
Yes.
Yeah.
We'll be sending it very soon.
When we
announcing the result of
our president, Dr. Halimuddin, has got the results. So he'll be announcing the results of the.
Number 1 is Dr. Bibhuti Kashyap. Number 2, Suchitra Kumari. Number 3, Payal Mukherjee.
Dr. Number 1, Dr. Vibhuti Kashyap is the winner of this.
And Dr. Suchitra is runner. And Dr. Payal Mukherjee is.
Congratulations, congratulations.
Number 4 is Dr. Neha Shilpi.
Yeah, Dr. 4 is Neha Shilpi.
Okay.
Shall I announce everyone?
A big congratulations to all the 3, Dr. Vibhuti Kashyap, Dr. Suchitra Kumari, this is number 2, and Dr. Payal Mukherjee.
Number 3.
Thank you so much.
If we are all done, I have a question for Dr. Partha.
Yes.
A very simple one, a practical one. When you are doing a trabeculectomy and if you're using MMC, the bud which you use, which is soaked with the MMC, do you keep on changing it to maintain the concentration of the MMC, or you just put it once and leave it for 2 minutes?
No, I personally, I still do glaucoma surgeries, trabeculectomies, I do, and I keep it for half a minute, change it to half a minute again.
Good, yeah.
So that is how, the concentration is as close to the concentration that we are placing in.
Thank you very much. Sorry for all these making you delayed.
And anybody want to ask any questions? What do you say, Dr. Bibhuti Bhushan?
Yeah.
The forum is open now. Anybody can interact.
Ask any question, any panelist. We have
the panelists, because it is our privilege to have such wonderful experts. So
what I suggest is, our youngsters, why don't you ask us some questions? I'm sure we are not going to be able to answer them, but we'll try and answer your questions.
Yes.
That is what I was suggesting, that it is a wonderful opportunity for them to interact with you.
So Abhishek is there, Antab is there. And
yeah, glaucoma, retina, cataract, anything.
Sab cheez. Yes, please ask.
Beyond ophthalmology, you can ask something beyond ophthalmology as well.
Yeah, one more question, Partha. One more question. The rule is if you're going to do some study, you have to take the permission of the ethics committee. But then, do you think that every kind of study has to go to the ethics committee and take the permission?
Yes, yes.
Invasive or topical or non-invasive or whatever.
Unless it is a basic science, project, anything that you deal with a patient has to undergo the ethics committee.
It may be eye drops, it may be non-invasive, it may be observations, or even observations.
And as of now, the protocols and the rules and regulations are becoming so stringent that it's time that possibly it's not going to be just signatures of these patients who have consented to your study and study protocol, but it will become a video recording of the consent that you have. So all this is coming to focus. Rupak, would you like to say something about that? Rupak, if you're there.
Yeah. So being a part of phase 3 trials. So all phase 3 trials definitely ethics, but again, except the retrospective study, rather analysis, I should say, all prospective, if you have a ethics committee approval, then the value of that study increases. So once it is printed or published, then it has some extra value, definitely it carries. And other than that, also, if you have ethics committee, then procedure, if you have in future also like some interventional study, and if it is going to have some effect, little of the court of law also, you are having a support of the ethics committee and you are little bit protected in that way. So that means kind of a protection that you have taken permission from the ethics committee, then this is the procedure can be done ethically.
No, if you go for ethics committee, the problem is now the ethics committee has to be registered with the government of India, and then calling ethics committee and putting out things forward. So it's not an easy job. So we have our registered ethics committee, but then we are calling them at least 4 times a year and as and when required. But this is what I said, that all the people in the ethics committee, the members are very high influencers, some are high court judges and all that. So it's that's why my question was whether all the cases, non-invasive, invasive, whatever, with the very little risk, to what extent should we take the permission from the ethics committee? So I'm clear. Dr. Partha told me that every case should be taken. Yeah, okay.
The other thing that I would really like to tell our youngsters that, when you do a study, think of publication. Because if you publish, your study is immortalized. So basically, you have to think to that effect that if it is a study with good results or whatever results, it should be something new, something different, something that has not done before, and get it published. Get it published in different journals. One quick tip I will give you for publication is that if a study you think qualifies for the local journal, send it to a journal of a higher category. You know it will get rejected, but the comments of that journal will put you on to a level that you will surely get it accepted in the next journal that you give. So you can modify the format of your study or the how you have tabulated and how you have come to the conclusion, and the criticism that comes is very, very important. So how many of our youngsters are listening, and how many of our youngsters think that there are no questions from the youngsters? Of course, Kashyap is always a youngster.
सब छुप छुप कर सुन रहे हैं. They have switched off their camera and they're listening to everything what you're saying. You're such a very important person, and your every word is a statement, and people learn a lot of things from you. So अभी सब कुछ छुप छुप सुन रहे हैं. कहीं उनसे फिर से कोई question नहीं पूछ.
Yeah, I think Dr. Bibhuti Kashyap wants to ask something.
Yes, sir, just a quick question on the surgical modification of management of pediatric cataracts. As you all, I mean, of course, as you demonstrated, the main rate limiting factor for the learning curve of a pediatric cataract surgery is A, the anterior rexus, and B, the posterior rexus. I mean, aspiration is it's a cakewalk basically. So what I want to say is that, anterior rexus can be mastered with the help of, initially with the help of a heavy viscoelastic like a GV. I believe personally in my experience that the posterior rexus, the performance of a posterior rexus, I believe, I may be wrong. I'm not challenging anything, because I'm predominantly a retina person and I do practice refractive and pediatric cataracts, but that is purely out of experience. So I'm not questioning. I'm in no authority to. So just a question. So to eliminate the learning curve of a posterior capsular rexus, what if we simply perform a cutter-based posterior, capsulectomy, because it is the lens is very elastic. So even if we create an iatrogenic rent, that is the purpose, it usually is a very circular one. It is not ragged like adult ones. And if we keep on cutting it bit by bit, we eventually end up having a pretty circular. I mean, that's how I do when I fail to achieve a proper glow. Then that is my go-to step for my rescue. And if that I can do so easily, why not replace that instead of doing a rexus, posterior rexus? And that's a pretty steep learning curve we are looking at. And when we do a vitrectomy, it just blunts that curve. So what do you think about that, sir?
Absolutely, Bibhuti, you're very correct. When you said that, and there are studies that have been shown that whether a posterior capsular rexus done by the forceps is equally effective to a vitrector capsular rexus. vitrector capsulorhexis after placing the lens in the bag, going under the lens, and doing a vitrector capsulorhexis. And Dr. Love also has a paper which compared and analyzed, and they are comparable, absolutely comparable. You can do it the either way. Actually, I learned it this way, so I still continue doing the capsulorhexis with the forceps, which I do accept that it is a little more difficult to learn, and it is easier and faster also to do a vitrector capsulotomy. It becomes a capsulotomy then. And in those cases in which we just showed that there was fibrosis of the capsule, there, of course, the vitrector has to be used there.
No, it just came
Dr.
to my
Bibhuti,
that is my
Bibhuti, you will be happy to know that Dr. Love is using vitrectomy cutter regularly for his posterior capsulorhexis. So right now he doesn't do it.
Oh, thank God, sir, because I thought I was the odd one out. I used to always question Chief on this.
I have been using it quite regularly.
To be honest, I have not read the literature on this. Quite honestly, it did not strike my mind because I was having fantastic results with that. But since we were here, I thought of just popping up the question. So I'm glad to know that this has already been. So I'm safe. My techniques will not be questioned. It's already been substantiated. Chief, I hope you're listening to this.
Yeah. Fine.
So one quick question to the presenter of the citicoline. Actually I got disconnected at that point of time. So that paper itself was a very good paper, and I would really congratulate
Payal Mukherjee.
Payal, yeah.
She is the second.
Yeah. So Payal, one thing that I had in mind, and I would have asked that at that point of time, is citicoline has actually been demonstrated to improve on the visual acuity in certain in amblyopic status, as well as in advanced glaucomata status as well. But they have lasted for some time, 4 months and 6 months, and then again they have regressed. The other thing that I had in mind for you is citicoline was used as an injectable form, which again is difficult to get passed through the ethics committee and protocols. So you used 500 milligrams of citicoline tablets. I don't know if Payal is listening there. Okay. She's not there anyway. So citicoline has really shown quite a few good effects, and I think longer trials are required for to show up for the citicoline. So I think we are done.
Yeah, let's call it a day, madam.
Okay.
Halimuddin sir, thank you very much, sir, for for this kind invitation, and but it's not an invitation, sir. It's homecoming for me, as I always say.
Yeah, as you always say.
This Payal is here. Payal is here. Payal, they are asking you some question. Please come. Okay. Actually, they liked your presentation, and you are the second winner. So, Dr. Partha Biswas wanted to talk to you.
She's number 3.
She's 3. Okay.